my topic is related to the post-CABG atrial fibrillation and its relation to the stem cell therapy. So the first slide will be the access to surgical care around the world. So as we know that cardiovascular disease is the leading cause of death worldwide, responsible for 17.5 million deaths every year, of which 80% occur in low and middle income countries. Unfortunately, some 75% of the world doesn't have the access to the cardiac surgery when needed because of lack of infrastructure, human resources, and also financial coverage. A total of 12,180 adult cardiac surgeons and 3,858 pediatric cardiac surgeons were listed in the cardiothoracic surgery network as per August 2017, equaling 1.64 adult cardiac surgeons and 0.52 pediatric cardiac surgeons per million population globally. Large disparities existed between the regions, ranging from 0.12 adult cardiac surgeons and 0.08 pediatric cardiac surgeons per million population in sub-Saharan Africa, compared to 11.12 adult cardiac surgeons and 2.08 pediatric cardiac surgeons in North America. Low-income countries possess around 0.04 adult cardiac surgeons and 0.03 pediatric cardiac surgeons per million populations, compared to 7.15 adult cardiac surgeons and 1.67 pediatric cardiac surgeons in high-income countries. So this slide will be the report of encompasses aggregate outcomes for all operations performed between January 1st and December 31st, 2019. As presented in the 2020 Harvest 1 report of the STS-ACSD available to the sites of participants, utilizing data elements in the version 2.9 data collection instrument. Consistent with the past reports, the 7 major procedures for which the STS-ACSD has developed risk adjustment models accounted for 75.7% of major cardiac procedures. Isolated coronary artery bypass grafting, or CABG, continues to represent more than one half of the roughly 300,000 annual procedures. As you can see here that the most commonly seen side effects of the major morbidity of CABG would be the new onset of atrial fibrillations compared to the other side effects. Next slide, please. Owing to the complexity of the surgery, numerous complications can occur during the surgery and post-operatively. Different measurements systems are exploited to predict those complications, such as Euroscore 1 and 2, which utilizes different variables to analyze complications and mortality in CABG patients. And also the Society of Thoracic Surgeons STS scoring system, which can compute the risk scores online. So this figure illustrates some common risk factors associated with various post-operative CABG complications. Complications can be fatally related, such as stroke, arrhythmias, such as atrial fibrillation, and also self-limiting, such as transient kidney injury and also respiratory infection. Most reported complications associated with CABG include thromboembolism, wound infection, renal, respiratory, and gastrointestinal event, stroke, myocardial infarction, and pericardial effusion, and also the post-operative atrial fibrillation, which comprises as the mostly seen post-operative side effects in CABG patients. Next slide, please. So the time to event curves and adjusted hazard ratios for the 3-year primary composite endpoint of death, myocardial infarction, or stroke in patients with left main coronary artery disease without pre-procedural atrial fibrillation who underwent revascularization by percutaneous coronary intervention versus the CABG with the subsequent development of new onset of atrial fibrillation before hospital discharge versus coronary artery bypass grafting without new onset atrial fibrillation before hospital discharge. So the 3-year adverse event rates were highest in coronary artery bypass grafting treated patients with the new onset atrial fibrillation, and similar in CABG treated patients without the new onset atrial fibrillations and in PCI treated patients. Next slide, please. So this is the stem cell mechanism for cardiac repair. Summary of the proposed mechanism for cardiac repair by transplanted stem cells. So stem cells secrete various factors with a paracrine effect on other cells, promoting cardiac protection, neovascularization, immunomodulation, and also endogenous stem cell activation, along with an autocrine feedback effect to enhance their survival. Interleukin 10 and then interleukin 1 beta and the other various factors were highly related to the therapy for the cardiac repair from the stem cell. Next slide, please. So these are the long-term follow-up results from a pilot study conducted in France during December 2002 to January 2007. So 7 patients, 5 males, 2 females, aged in the range of 33 to 72 years from France who had experienced a myocardial infarction with a very poor prognosis were enrolled in a pilot clinical study to receive intraepicardially autologous peripheral blood CD34 cells at the end of CABG surgery without reperfusing this ischemic area performed on a compassionate basis. So the main criteria for selecting the patients were LVEF under 35%, age under 75 years, distinct area of akinesia corresponding to the infarct localization detected by bidimensional echocardiography, and also distinct area of non-viable and non-perfused LV myocardium detected by a PET scan examination, PSE, after intravenous injections of 18-FI FDG and also 201 TI chloride, respectively. Class 4 exercise capacity according to the criteria of the NIHA, a non-reperfused ischemic area, and an indication for CIBG surgery on the coronary artery other than the obstructed vessels. After the patients signed the informed consent, they were assessed with the echo and then allowing the determination of the LVEF. Once the date of CABG was scheduled, CD34 cells were mobilized from the bone marrow into the peripheral blood by the subcutaneous administration of granulocyte colony stimulating factors. As recommended for further satisfactory selection procedure, when the collection was poor, a second LKP was performed early in the morning of the 7th day, and then the whole LKP products were then processed for CD34 immunoselection with the clinical Isolex 3001 magnetic cell separation device. The CIBG and cell injection were performed 11 weeks after the acute myocardial infarction on average, ranging from 6 to 24 weeks, excepted in patient number 1, 8 years later. Patients were further assessed by echo 3D at 3, 6, 12, 18, and 24 months with 201 thallium scintigraphy and PSE at 6 and 12 months post-surgery. Next slide, please. So I would like to discuss about the PET scan result from the patient number 2. So this is the impact of stem cell therapy on post-CABG patient number 2. So this patient was a female, 49 years old, overweight and a smoker with high blood pressure, familial dyslipidemia, previous left retinal artery thrombosis. So on 2002, she complained of gastralgias that increased on the next day with the occurrence of intense dyspnea, sweating, restlessness, coughing, and foamy sputums, which are symptoms of acute pulmonary edema. She was then transferred to the emergency hospital 48 hours after the appearance of the first symptom. So the treatment of the APO was immediately launched. A CAG showed that a 3-truncal obstruction of LAD2, MG, and D1CA, which were responsible for an extensive anteroapical, as well as a transmural MI with severe alteration in LV function, and a truncal obstruction of the right CA. Extended anteroapical akinesia and a marked LV dilatation were recorded. The apex and one half of the LV anterior wall did not fix the 18 FDGs. The patient suffered from the angina during effort and was classified as NIHA class 4. So this is the PET scan of patient number 2. So the upper row portion of the large non-viability area, the red square in the left ventricle anterior wall before cell injection, and the middle row was the cardiac tissue regeneration 6 months after cell injection, objectified by fixation of 18-FI FDG into what was the dead area, red square, and then lower row. The fixation of 201 Ti chloride 6 months after cell injection, showing the revascularization of the initially dead area in the yellow square. Next slide, please. So this is the PET scan of the patient number 4. So the patient was female, 33 years old, alcoholic, and a smoker. So she had already suffered for several years from transient precordial pain after vigorous exertion. So on March 2006, after a prolonged effort removing snow, a brutal and intense squeezing thoracic pain suddenly occurred, irradiating to the left arm and the neck, associated with dyspnea, palpitations, tachycardia, and vomiting. The patient was rapidly taken to the emergency service where a cardiogenic shock was performed. ECG and echo three-dimensional showed respectively an elevated ST and severe LV dilatation, a severe diffuse hypokinesia only sparring the basal third of the LV, and her LVEF was 25%. The CAG highlighted a bitruncal coronary relation with an old obstruction of the proximal ALB ostium and a subocclusive stenosis of the distal section of the middle right coronary artery. 201 thallium scintigraphy confirmed the large transmural MI, including of the aneurysmal apex, the anteroseptal junctions, and two-thirds of the LV anterior wall, the intraventricular septum, and the apical third of the posterior. I'm sorry. So let me continue. The patient was very dyspneic and was not able to walk more than 10 meters, so as classified as NIHA class 4. In total of the CD34 cells were transepicardially delivered at the end of the mono CABG LAD performed on April 2006. No adverse event was reported within the post-operative period, and the patient was progressively improved his physical capacities with the 6-minute walking test of 400 meters and less dyspnea. She returned home on May 13. And then after that, however, at the 6-month assessment, not only was the patient still alive, but all evaluation parameters began to clearly improve. LVEF 22% and slightly recovered of the viability and reperfusion of the posterior inferior wall. This improvement increased for months. The 1-year assessment showed good recovery and viability and perfusion of the posterior inferior wall, and a partial recovery of the viability of the anterolateral wall. So at the 2-year follow-up, his LVEF had gained 16 points from the third month, and the patient was in a good clinical condition without any symptoms of heart failure and had progressively resumed physical activities and classified as a NIHA class 1. At the 4 years, her LVEF remained stable at around 30%. The patient felt really well and was capable to ride a bike for 60 kilometers 3 times a week, to swim 100 meters continuously, and to play basketball for half an hour. And then he walked 6 kilometers every day. So thankfully, the patient survived and still alive. And then 17 years after stem cell therapy, she is now 50 years old. The last cardiac assessment performed in January 2023 showed a clinical stability with a persisting NIHA class 2 LVEF at 15% and marked LV dilatation. Next slide, please. So this patient was a male. Patient number 5 was a male, 72 years old. He had experienced a previous inferior MI, by coronary obstruction in 1996, which was treated by angioplasty. In January 2006, the patient was hospitalized because of dyspnea and left lateral thoracic pain that had been progressively increasing for the last 2 months and was associated with transient atrial fibrillation episodes. An echo 3D revealed a severe transmural MI with akinesia of the postural inferior wall and of the septum, related to prior MI. Alongside several severe anterolateral hypokinesia, LV dilatation, and LVEF at 27%, the CAG identified a brief truncal involvement with a 70% stenosis of the LAD and a subocclusive stenosis at the proximal coronary, which was immediately stented. 2 months later, the median LAD was also stented. The patient was well until the end of the June when he felt dyspnea again with severe angina resulting from the slightest effort. His LVEF was 30%, the apex, the anteroapical wall, and the basal septum were akinetic, as well as the postural inferior wall, the site of the first AMI. A new CAG showed restenosis of the both LAD and coronary at the stents level. A PSE showed two separate areas of non-viability, one in the posterior inferior wall, corresponding to the scar of the first AMI. The second was larger, comprising the apex, the third inferior segment of the anterior wall, and the apical part of the septum. The patient was then scheduled for CABG plus CD34 cell therapy and recommended for further heart transplantation, but the patient refused. So in total, after the stem cell CD34 cells were intraepicardially delivered at the end of the triple CABG, LAD, diagonal, and coronary performed on August 2006. The post-operative period was good enough. The patient became asymptomatic and recovered with some physical capacity, improving still more within the following months. At the 6 months follow-up, this LVEF function reached 40%, correlated with a recovery of the anteroseptal-lateral area viability and kinetics. However, a supraventricular arrhythmia access occurred in the ninth month, resulting in a sudden decompensation of the left heart function, NIHA class 2, and a drastic drop in LVEF 20%. Requiring the implantation of the defibrillator, he then improved with the LVEF value progressively increasing once more. Furthermore, at the 1-year follow-up, a significant regeneration and reperfusion of the ischemic zone that had been treated by cell injection was recorded, contrasting with the mute scar of the oldest infralateral AMI, which thus appeared as an internal negative control. Throughout the following 10 years, the patient did very well, leading a normal life with a good enough physical capacity. While his LVEF remained stable around 40 to 45%, he was classified as NIHA class 1, and he no longer required heart transplantation. However, on March 2018, almost 12 years after CD34 stem cell therapy, he suddenly died of a stroke during the night. He was 84 years old. Next slide, please. So in severe case of MI, such as those reported here, CABG surgery is only compassionate and does not prolong life expectancy, which was less than 5 years at the time of the study. Furthermore, the patients become more and more handicapped by the progressive decomposition of the CHF, the evolution of the which of interspersed with numerous hospitalizations, which also leads to very high healthcare costs and make it more difficult to have any social professional life until death. Thus, the long survival achieved by 6 out of 7 of the AMI patients reported here averaged from 70 years, range from 12 to 20 years, 3 of whom having even avoided the heart transplantation. They were initially recommended. Finally, reviewing the literature and our present data, it seems that to be potentially efficient in AMI, the injections of CD34 cells should be carried out at the highest cell dose possible with a minimum threshold. And then also the second one is intramyocardially rather than intracoronary. And then the third one before definitive remodeling of the scar, which induces the onset of congestive heart failure. Of course, we are aware that the fact of our study was a pilot study. not randomized, not controlled, and only enrolled a small cohort of patients. However, its long-term outcomes were impressive enough to encourage us to launch another study in which the AMI patients are randomized either to a cell-treated group receiving endocardially autologous peripheral blood CD34 cells, GMP expanded in vitro via a proprietary automated devices, and also disposable cell culture kits that we have already developed. So the next slide, please. So the key points and the future prospects, stem cell therapy holds a significant promises in addressing post-CABG atrial fibrillation. However, further research is needed to optimize safety, efficacy, and also clinical applicability. Standardization of protocols for cell type, dose, and also delivery of methods are needed, and then also establishing guidelines for the clinical translations of stem cell therapies through post-operative atrial fibrillations are still needed. Thank you for the time and thank you for the listening.
Greetings, everyone. My name is Victor Chigbundu, and I'm really happy. I'm excited to be a part of the fourth international webinar on cardiology. I really want to appreciate Scientex conferences for such a job well done, and I'm really, really excited to be a part of this great movement. For today, I will be discussing on a very, very important topic, and this is a topic that is going to be a little bit more practical because it's something that we all have at some point undergone. And so the title is Emerging Multifaceted Application of Artificial Intelligence in Chest Radiography, a Narrative Review. So let's get the ball rolling. I'll be working with this outline. Introduction. Chest radiography, otherwise known as chest X-ray, is the first-line examination requested in patients that are presenting with chest pains, with shortness of breath, with cough, with metastatic diseases, and of course with malignancy. And that image, I believe, is not new to over 90% of us, because at some point, we might have visited the hospital, we might have had chest X-ray for one reason or the other. And these things are some of the things we experience in the clinical setting. And so it is actually the first examination that your doctor would always require of you when you present with some of these findings. Now, chest X-ray supports diagnosis. Of course, it supports treatment. It supports the management of thoracic-related diseases, okay? And it plays a very key diversifying role in the diagnosis and management of rising respiratory diseases that we have witnessed worldwide. In fact, as we speak, there's been a surge in terms of the reported cases and the prevalence of respiratory diseases we are seeing, whether it's pneumonia, whether it's COVID, whether it's emphysema, whether it's pulmonary mass, and all that. It's on the high. And so chest X-ray plays a very important role in that, in diagnosing and in management as one of the first line examination that you request in these cases. Of course, it plays a very important role in pre-employment for some of us that would have undergone this examination before assuming our roles, our responsibilities, our duties, taking up job offers. So it's part of a very key assessment that is required for pre-employment purposes. Of course, for migration purposes, some of us that will be traveling abroad, traveling to different countries. For some countries, we have specific guidelines that you would have to do a chest X-ray. Probably they want to screen you for TB and other chest-related diseases. So you would definitely do this examination. Of course, for pre-operative, very important, a couple of surgeries that you'd want to undergo, and your doctor would ask that you do a chest X-ray before taking you to the theater. And then for periodic health checkups, yes, very, very important as well. And so these cumulatively makes chest X-ray to be very, very common, and one of the first line examinations you would always undergo when it has to do with anything that is related to the chest region. Now, chest X-ray is currently the most widely performed, like I said, it's the widely performed examination as we speak in the radiology department. In fact, it's already placing so much burden on radiographers, on radiologists, and the entire health system, especially in low resource settings. So because you see that the workload is so much on radiographers, the workload is so much on radiologists that are reporting these cases, you discover that we have long waiting time, we have fatigue-based technical and interpretation errors, we have lots of reporting delays, we have backlogs, we have longer turnaround time, and these are issues that we need to look at critically, especially in a society now where we're looking at patient-centered care, we're looking at quality improvement in our health services that we render to patients. And this is where artificial intelligence has come in. In fact, it's been projected to be one of the major disrupting forces in radiology. And it has a lot of ability to respond to these challenges that I have mentioned and to do this very importantly in a timely manner. But then AI is still in its early stages. And so this review would help us to see the level of progress or ascertain the level of evaluation of progress or productivity that has been made, and then we can see research gaps, okay, for future studies, and this would help us very importantly in supporting routine clinical implementation. It would also help us in policy making and enhance clinical governance. So the methodology, it's simple. What I had to do here was to search for relevant literature that focused on artificial intelligence techniques in chest radiography. Don't forget that this is going to be a narrative review. So it's time for stories. We're going to see exactly what happened in each of these studies. Now, I had to consult lots of database and sources that were searched, such as the PubMed, Web of Science, a couple of those databases. I believe they are very, we are used to them. Now, the selection processes was done by a team of experienced radiographers and radiologists, okay? And they did this together. They had to pool their knowledge and areas of expertise as it relates to chest X-ray. Now, the inclusion criteria was very simple. Any study type that has been conducted any year, but then studies must only be in English, okay? And then for the search terms, we had to use a couple of them. We had artificial intelligence, we had chest radiography, machine learning, deep learning, language processing, expert systems, Fuchs logic, and the rest of them. All right. So these are some of the areas that we employed. And in a way of analyzing our data, we had to carry out some sort of synthetic organization where we had to, the evidence was analyzed per each of the domains of artificial intelligence. And we had to do this in a way that would highlight the current benefit, we'd see the challenges, we'd see future opportunities to improve our detection rates and patient and clinical outcomes. So let's look at the discussion now quickly. Under artificial intelligence domains in chest X-ray, we have about, I think that's about 6 of them, but I'll try as fast as I can to touch all the areas. Okay, so let's get the ball rolling. Now, the first is machine learning. This is a very important aspect of artificial intelligence, and we have lots of algorithms that play a very important role in known diagnostic tasks for quality improvement purposes, as we see in radiography. Now, the first is the aspect of exam scheduling. Recently, we've discovered that lots of algorithms has been put in place that has a scheduler that you can actually schedule patients that want to do chest X-ray, okay? And so you do not have to, the data entry, the request for chest X-ray, preferred time, locations, all of that, the scheduler does that. And this is courtesy of machine learning algorithms. So imagine you're scheduling patients, it does a lot of work. A lot of work has been off from the shoulders of these radiographers and radiologists that have been saddled with so much work. There's been integration of machine learning with natural language processing tools, okay? And we see this in the scheduling software, and this helps us in a concept called the electronic round trip. In other words, the patient places an order for a chest X-ray, and there is no form of written or manual entry. Everything is computerized. So from the point that the patient is placing this order, it gets to the electronic health records. And from there, you have this information in your radiology information system. From there, it gets down even to your picture archiving and communication system. So it helps a lot in the workflow in that order. All right. But then there's been lots of issues as regards this, because it does appear that it's limited to a particular institution. So we expect to see robust validation in this angle. Now, we have the aspect of work list management, and it's another very important aspect too that machine learning plays in chest X-ray. So in this case, we have certain algorithms that have been made in such a way that it can actually predict wait times. These data have been trained, and they can actually tell you the appointment delays. They can actually tell you those that are going to come late due to some certain environmental conditions and factors. So what happens is that the moment the algorithms tells you that, oh, this patient is going to come late, you'd expect that you're going to put up a phone call across, okay, to remind them. And it has really helped in reducing the number of no-show rate All right. And of course, if you need to prioritize some certain examinations, instead of having to go through the normal serial way of first in, first out, these algorithms can actually prioritize your work list so that those that have critical findings can be given preference in interpretation. All right. But then most of the drawbacks here is that the studies here are retrospective, and it used lots of historical label data to train algorithms. So we expect that we need to see prospective studies in this regard. All right. The next is the image acquisition. And what I just want to point out here simply is that the machine learning algorithms are able to detect inadequate positioning, all right, for patients that come for a radiological examination. So it has lots of techniques that can help you to ensure that there is reduction in the radiation dose that is given to the patients. We have also certain algorithms that play a very important role in noise reduction in the image. Okay, so at the end of the whole day, your image is beautiful. There is adequate receptor sensitivity, there is image acquisition that is being optimized, and there is of course reduction in without reducing the quality, reduction in the image quality, and of course the reduction in the dose. But then we need lots of scientific proof to validate this claim. Now the next is image interpretation, and this is where we have some sort of algorithms as well that are playing a very important role in trying to detect or interpret some chest X-ray findings. Now, a lot of these applications were seen in the previous computer-aided detection systems where we had lots of machine learning methods, okay? We can see them there. But then we discovered that as data keep growing, the challenge was how can you actually determine other features, okay, of chest pathologies in chest X-rays outside of the TB and the lung cancer that are common? And that was where we had to lead us to what we know as the deep learning. All right. Now, deep learning is one of the prevalent methods that we use to detect, to characterize, and to monitor all sorts of chest X-ray. A key feature of the deep learning technology is that instead of using the traditional computer-aided detection system, it actually uses networks known as neural network. Most importantly, we have the convolutionary neural network, that's CNN. And this network is organized such that it mimics the way the brain functions, and it has lots of layers. It has the first layer, the second layer, and the third layer. And all of these layers helps to aggregate, put informations together, and to provide a definite inference. Now, it has been very useful in the classification of several chest anomalies that we have seen, and it has really, really helped in terms of improving the sensitivity as well as the specificity. Now, we have a couple of studies here. Due to lack of time, I just want to pick maybe one or two of them. Most importantly here, we could discover, because we had to pick up studies that could enable us to do a bit of comparison between deep learning and radiologists. So which of them gave us most sensitivity and most specificity in terms of reporting chest X-ray findings? And we discovered that in the first study, there was no statistical difference. And then we tried to carry out another study for cardiomegaly and emphysema. We saw that, oh, yes, actually, radiologists were better than even this technology. But then this technology was also better in some certain anomalies, okay? And then we also carried out lots of other studies. We saw indeed how deep learning can actually improve radiologist reporting. It does not have to replace the role of radiologists, but then it actually aids a lot in ensuring that accuracy, sensitivity, and even more specificity is attained. And these were highlighted in a couple of the studies that we were able to pick. Now, the superiority of deep learning in most of the cases I had mentioned was actually accompanied with very high false detection rates, and this is very, very worrying. And like I said, most of these studies are retrospective, and of course, they are limited to a particular location or a particular institution. So we need more of these studies that would validate deep learning in real-world settings for chest X-ray interpretations before we can talk of routine clinical implementation. The next is natural language processing. Now, natural language processing is a very, very key aspect, and it has to do with the ability for systems to actually be able to process informations in form of text. So these data have been trained, and they can see text, and they can recognize them, and then they can actually produce reports. They can generate reports based on its ability to recognize text in certain context. Okay, that's very, very important aspect of natural language processing. And we've discovered that it has been very helpful. We had seen lots of algorithms in place that have been able to improve the sensitivity and specificity, as seen in the 41st study we used. In fact, we had to incorporate it with the deep learning known as the CNN, and it actually helped us a lot in giving descriptive findings. We could also discover that when we had to incorporate the natural language processing with the machine learning record, it actually improved accuracy. We can see the values there. And of course, the transformer-based language model also was very promising in terms of giving us very good area under the curve values that we can actually see. And it's very, very interesting to see all of these. All right. Now, we also have a case of where natural language processing derived labels and radiologists derived findings, and then we discovered there was a poor level of agreement, okay, where we had the kappa coefficient of about 0.34, okay. But then these studies were with varying degrees of sensitivity and specificity. So therefore, due to the variation in radiology reports and the highly challenging task of creating labels, we did more and more research in the aspect of natural language processing. Now, the next is robotics. And we've discovered that robotics is simply a system where we have robots that are built and programmed to perform certain duties, okay? And then this has been seen in healthcare, but most importantly, in the aspect of chest X-ray, we've seen robotics that has been created that helps in acquiring this image, okay? It helps in positioning the patient. It has lots of artificial intelligence features that can enable you to have a full body image that's been obtained. And in fact, the robotic technology improves accuracy and sensitivity in lots of studies surrounding COVID-19 in chest X-ray. But then there are issues with the use of robotics. There is actually high computational demands, okay, and it's compared to the low computational capacity of these devices, and this aspect is yet to be addressed. So we expect to see extensive creative research by way of creating new models that would help to address some of these challenges. Now, the next aspect is, my cursor cannot move. Just a second. All right. We have expert system. Expert system is another very important domain of artificial intelligence, and it has lots of computer programs that is able to reciprocate judgment. So what the expert system does is that it has several components, 3 of them. It has the knowledge base, it has the inference engine, and it has the user interface. So it accumulates all the experience and it puts it on the knowledge base. It integrates them into some sort of rules, and then it provides an answer to a problem. So you see how it's actually beginning to mimic a way human being reasons and takes actions and reciprocate judgments. Now, we've actually applied this in several studies that has been seen, and it was able to detect pneumonia. In fact, it performed at par with machine learning and even the physicians in the same capacity. But then the issue with the expert system is that because knowledge continues to increase, you discover that the processing complexity also increases of expert systems, and there are lots of computational errors. And so you have issues of overfitting, issues of overgeneralization, and these have not really been adequately addressed. So we expect to see even a more clearer approach to rule-based technologies in order to improve health outcomes. Lastly, we have fuzzy logic. And fuzzy logic is simply a situation where you don't know if the answer is true or it's false, and then you're confused on what do I do. So what fuzzy logic does is that it actually works on the principle of approximation and inference. So it gives decision based on how much information it has in terms of the abundance of data it has been able to accumulate, and then it actually tells you the answer. So in cases of where truth or false cannot be made, fuzzy logic algorithms has played a very important role there. As you can see in a lot of studies here, it has improved the accuracy of pericardiac areas. It has improved on cardiomegaly. You could also see it being able to detect lung cancer. It has also helped in detection of COVID-19. Okay, incorporating it with deep learning has also helped to tackle issues of vagueness, issues of ambiguities, and all of that. So this shows the promising role that fuzzy logic does. Now, the accuracy of fuzzy logic system is always compromised because the system works mainly on inaccurate inputs, okay, inaccurate data that have not been verified. And that's the reason why results from fuzzy logic in most of the cases are not usually widely acceptable. And so it makes it a little bit sometimes very confusing. So what most people have actually proposed is a combination approach where you use fuzzy logic with other forms of neural networks just to improve accuracy. All right. So the summary. All studies that were discussed in this literature across AI domains, we had to look at the strengths, we had to look at the limitations, we had to look at the gaps, and then we have a lot of them here. We'll not have time, I will just highlight them. We had several literatures about, this is the 9th to the 21st literature. We also have the 22nd to the 35th, and then we had the 36th to the 47th. So we had about 47 studies that were picked out that cuts across all the domains of AI. We're able to look exactly at the strength of these studies. We had to look at the limitations, and then we look at the gaps. And we have over 30 gaps. And these are areas that are very prone, and people can carry out research to see how they can improve, of course, artificial intelligence in improving the detection rates. And of course, the overall effect it has on chest radiography exercise in the radiography department. So we have lots of areas that are available, and we need to do future research. Conclusion: machine learning can be very useful in certain administrative task in chest X-ray. As you can see, it's very useful and you can schedule your exam. You can use it to manage your work list. It has helped us in the image acquisition process, as has been shown. However, deep learning has shown very promising sign as regards interpretation. But like we've pointed out, we had the issue of the expert systems. We had to point out a lot of limitations. The issue of the aspect of, the fuzzy logic that had lots of computational errors, that had lots of inaccuracies in data. We said that a hybrid approach where you're going to combine probably a deep learning and a fuzzy logic, you combine a deep learning and an expert system, that gives us even more and more insight, or probably even a deep learning and a machine learning. It will give you a very good information you need, a holistic one that concerns everything surrounding chest X-ray examination. So it is highly recommended that more in-depth research be conducted to address limitations, to justify implementation, and lastly, to tackle policy issues. Thank you. These are my references.
Let me introduce myself. My name is Ibu Wiryaputra. I'm from Kasih Ibu General Hospital, Gianyar, Bali, Indonesia. Now I will present a case report with the title of middle cerebral artery stroke in chronic heart failure patient. Before I begin, I would like to address clarification regarding to the focus of my presentation. The case I will be discussing involve a stroke occurring in the context of heart failure. While this may appear to deviate slightly from a pure cardiology focused topic, I essentially believe it highlights to integrate relations between the brain and the heart. My hope is the case will provide a valuable insight into the complex case of the patient overlapping with cardiovascular and cerebral vascular condition. Thank you for your understanding. Now I will start off my presentation. Middle cerebral artery, or we abbreviate as MCA, is the largest cerebral artery commonly affected in cerebrovascular accident. The MCA stroke described as the sudden onset of the focal neurologic deficit resulting from hemorrhagic or ischemic disruption of the MCA's blood supply. And also the chronic heart failure is also the common cause of the ischemic stroke. The most frequently recognized reason for the cardiac embolic stroke in patients with chronic heart failure are thrombus formation, maybe due to the atrial fibrillation or left ventricular hypokinesia. Also, there is some evidence that endothelial dysfunction may be caused in the chronic heart failure patient, can cause ischemic stroke because of the increased blood velocity, or maybe because of malfunctional cerebral autoregulation. And also we should know that chronic heart failure and ischemic stroke share common risk factor such as hypertension and diabetes. So it will be more concurrent subtype stroke that to be taken into the account. So for my case that I present, the patient with 66 years old male with chronic heart failure since 3 years with the echocardiography with systolic dysfunction with the ejection fraction in the last month is 40%. Patient came to the emergency room at the Kasih Ibu Gianyar Hospital with complaint of suddenly not being able to talk since 8 hours before entering the hospital. There is a weakness on the right side of the upper extremity and weakness on the right and left lower extremity. The patient has a history of chronic heart failure since 10 years ago, since I said before. Patient was on routine treatment with bisoprolol, clopidogrel, simvastatin, and also nitrocalf. On the physical examination with vital signs show there is some hypertension stage 1 with blood pressure is 142 under 74. And the other vital sign is in the normal limit. In the neurological finding, we found that the Glasgow Coma Scale A4, verbal X, and motoric 6. It means there is a motor aphasia with parasa in nerve 7 dextra and hemiparesis dextra. Then patient underwent a complete blood count, blood sugar, kidney function, and liver function tests. In this patient, we found that examination in the normal limit. Next, the patient do the echocardiography test, and we at the time we see that it seems to be in the normal limit. Then we do some CT scan of the head without contrast, and we found some clinical significant finding there is some acute thromboembolic ischemic infarction in the left temporoparietal lobe. It means there is some it in the middle cerebral artery territory. Also, we do some thorax X-ray, and we found there is some atherosclerosis in the thorax region. So, for the management of this patient, the patient received treatment with the approach was multidisciplinary. The patient received treatment for two specialists, a neurologist and a cardiologist. A cardiologist focusing on heart failure management, and neurologist addressing a stroke rehabilitation. Cardiologists prescribe medications such as beta blocker and anticoagulant that the continue of the routine treatment before with additional therapy for summit. This point to manage the patient chronic heart failure and prevent further thromboembolic event. For the neurologist management, implement the stroke management therapy, including antiplatelet also, and neuroprotective medications such as clopidogrel, citicoline, atorvastatin, and mecobalamin, alongside with physiotherapy to enhance motor recovery. Patient after arrive in the emergency room decide to the quad stroke and inpatient hospitalized for 5 days. By the 5th day, patient showed a clinical improvement with Glasgow Coma Scale score A4, verbal 5, and motoric skills, and improved motor and strength and sensation. For this discussion, large medial cerebral artery stroke are usually the easiest recognized as stroke. They tend to be present the myodeficit that we know about the stroke, such as unilateral flaccidity, hemiparesis, and speed deficit. As in the case we present, the patient aged with 66 years old with symptoms sudden neurological deficit, where there is some disturbance in sensation and strength in all four extremities, and speech losses will clinically indicate as stroke in the middle cerebral artery territory. And heart failure is common cause of ischemic stroke because heart failure is defined also as the inability of the heart to supply sufficient blood flow to meet the body metabolic needs. Clinical symptoms that we know of the heart failure including breathlessness, fatigue, tiredness, and ankle swelling. However, beside of the typical sign of the heart failure, also there is some objective evidence in the structural or functional abnormality of the heart, like there is some we found the cardiomegaly, we found cardiac murmur, abnormal echocardiogram, or raised natriuretic peptide. Whereas ejection fraction is decreased in a heart failure patient with systolic dysfunction, and also EF is normal in this patient with this diastolic dysfunction. In our case, the patient age 66 years had experienced chronic heart failure for 3 years with systolic dysfunction with ejection fraction is 40%. We believe that the most common heart failure pathophysiology mechanism related to the stroke is increased thrombotic formation caused by several underlying causes, such as increased prevalence of left ventricular hypokinesia, or maybe decreased left ventricular ejection fraction. Increased prevalence of atrial fibrillation and increased blood viscosity also make contribute about there is some thrombus formation. Beside of there is some atrial fibrillation. In addition, chronic heart failure and ischemic stroke also both entity represents manifestation of similar underlying risk factors such as hypertension and diabetes mellitus, that same as our case that the patient have hypertension, also make the patient have higher heightened of risk to be there is some cardiac disease or cerebrovascular disease because of the same of risk factor that the patient have. So for my conclusion of my case report, that patient with middle cerebral artery stroke often have underlying cardiac heart failure, and the pathophysiology of chronic heart failure increase the risk of ischemic stroke in major brain vessel. So early recognition and management of chronic heart failure and also stroke risk factor are crucial for prevent there is some cerebrovascular accident, disease, and also cardiac disease. Thank you for attention.
Present on the topic on the webinar. Fourth International Heart Conference. I am very much grateful as they invite me to this webinar. My presentation is a case presentation, that is the Mycobacterium endocarditis, a very, very rare case. This is all about my disclosures. And Mycobacterium endocarditis is very rare case. Endocarditis is referred to as the infection in the endocardium, the inner lining of the heart chamber, and the heart valves. In the United States alone, approximately 15,000 new cases of infective endocarditis are diagnosed each year. Infective endocarditis has an annual incidence of up to sorry. Sorry. Infective endocarditis has an annual incidence of up to 10 per 1 lakh of the general population and carries a mortality of up to 30% at 30 days. And we know the modified Duke criteria are used to help establish a diagnosis of endocarditis. The introduces the use of molecular imaging technique for implanted heart valves, where conventional echocardiography has reduced sensitivity. The Mycobacterium tuberculosis itself is exceptionally resistant to conventional antibiotics, so requiring multiple drugs like isoniazid, rifampicin, ethambutol, pyrazinamide for a long time, months together. Mycobacterium tuberculosis yet remains a global threat, being a major cause of death. It is the potential to infect every organ of the body, including the heart. Can Mycobacterium tuberculosis causes endocarditis? Yes. The first reported was 1892. First reported case, Mycobacterium endocarditis, and subsequently many other cases have been described, highlighting the significant morbidity and mortality associated with this manifestation of tuberculosis. Tuberculosis endocarditis is usually present with miliary tuberculosis, and most early cases were diagnosed on autopsy. With increasing application of prosthetic valve replacement in the treatment of infective endocarditis, TB infection have begun to affect these as well as the native valve. So it involves both valves, native and prosthetic valve. With the introduction of TB culture method and drug therapy, the prognosis has improved. And we know the granulomas caused by the Mycobacterium tuberculosis have been observed at autopsy in heart, predominantly in the myocardium and endocardium, but rarely involving the coronary vessels and valvular structure. So, TB endocarditis involve the pericardium, myocardium, endocardium. And summary of the available management of tuberculosis endocarditis through time. We see in 1900, the only treatment, dead occur, autopsy, histological observation. In 1935 to 1950, treatment, date, autopsy, and then come the acid fast staining. The gram acid fast staining come at that time, FBS staining. And after And in 1950, then echocardiography has come, and then TB culture method has come, and valve replacement also occur in that time. So all this together, by echocardiogram, by doing TB blood culture, by and also in the valve replacement, prosthetic valve replacement, in that all this shows a dramatic change, like anti-TB drug, and also diagnosis of the TB by culture method, and also echo is a helpful here. And my case report is that Mr. M, a 5 years old boy, presented to our cardiology department, Rangpur Medical College Hospital, Rangpur, Bangladesh, with a history of fever for 20 days. And he had also a history of respiratory distress and malaise for 14 days. On examination, the patient is toxic and dyspneic. Anemia present, temperature raised, respiratory rate 30 breath per minute, JVP is raised, and first and second heart sound are soft. And we have done some investigation, and the hemoglobin level was 9.8 gram per DL. The patient is anemic, and WBC count is 11,000 per cubic millimeter. ESR was 50 millimeter in the first one. And we did chest X-ray, posterior anterior view. Here they show the huge cardiomegaly with globular or pear-shaped heart with clean card margin, and the lung field is oligamic, the huge cardiomegaly. What may be the possibilities? So then we go for the echocardiogram, and on echocardiogram we see severe pericardial effusion, that is 27 millimeter posteriorly, the echophyreal space, and 13 millimeter anteriorly, and 20 millimeter laterally on the LV side, and 70 millimeter on the RV side. And there is the feature of early pericardial tamponade, that is the raised JVP, and also there is the raised RA and RV pressure, and the filling RA and RV filling is reduced, and also decreased blood pressure, and also cardiac output decreased. And the heart is swinging around the fluid with the early diastolic collapse of RV and late diastolic collapse of RA, and dilated IVC, infravena cava, and there is no paradoxical collapsibility is also impaired in infravena cava. And the one echocardiogram we also see in the pericardial effusion, there are multiple tentacles. What is the tentacles? That is the echogenic fibrinous strand were also found in the pericardial fluid. These are the linear structures which is found in the pericardial fluid. This is the sign of inflammation, as the fibrin exudation occurs in the pericarditis. And interesting thing is that there was also vegetation attached to the tricuspid valve, and also vegetation attached to the mitral valve. On the tricuspid valve, vegetation attached to the anterior and septal leaflet of tricuspid valve, that is the upstream side, that is on the atrial side, low pressure side of tricuspid valve. And vegetation also attached on the left side of the heart, that is the mitral valve, on the PML, posteromytal leaflet, on the atrial side, there is vegetation. Vegetation shown a oscillating movement. As we know, there is the vegetation, maybe different sizes, and there is different movement. So on echocardiogram, we find there is severe pericardial effusion with sign of pericardial tamponade. There is tentacle and also vegetation on the two halves. And interesting thing is that the echo showing pericardial effusion with vegetation seen in the tricuspid and the mitral valve. This is the tricuspid valve, this is the mitral valve. There is the vegetation, and also there is, you see here, the pericardial effusion. And we see vegetation attached to the tricuspid and mitral valve, and also there is pericardial effusion with collapsing RA and RV. So, large vegetation in the tricuspid valve with pericardial effusion. So, what should we do? The patient is in pericardial tamponade with large vegetation. What should we do? Patient is very much toxic. He cannot sleep. So, we go for pericardiocentesis. And it was done. And 300 ml milky color pericardial fluid was aspirated and sent for examination. So, here, as soon as the pericardial fluid was drawn, the patient feel comfort and the relief of respiratory distress. The 5-year-old boy with huge pericardial effusion, with fissure of tamponade, we draw this fluid, milky color pericardial fluid by pericardiocentesis under all aseptic measurement. And the pericardial fluid study, the result come ADA, that is the adenosine deaminase test, is 195 unit per liter. Normal is 40 unit per liter. And this ADA is highly sensitive for tuberculosis. And the protein is 9 gram per dl, sugar nil. So that is the exudative pericardial effusion. Why milky color? Milky color may be the involvement of the lymphatic exudation occurs. Lymphatic involvement and lymphatic exudation in the pericardial space causes the fluid, the milky color. And pus cell was plenty and no malignant cell. And FB staining, there is the ZN Ziel staining present, FB present there. So, with this, we started treatment and blood culture report. The traditional blood culture report, no growth of bacteria, but TB blood culture not done because it needs, this is the one of the limitation because we have already started treatment. The patient get antibiotic treatment, and TB blood culture needs weeks, couple of weeks, 6 to 8 weeks may be needed for the Lowenstein Jensen media blood culture method. But we already started antibiotic and its result is coming positive. So, with this scenario, what may be the diagnosis? And the diagnosis is tuberculous pericardial effusion with mycobacterial endocarditis, because the Mycobacterium tuberculosis involving the pericardium, also involvement in the endocardium. There is large vegetations involving the tricuspid and mitral valve, and also in case of the pericardial fluid study, ADA positive, there is the AFB staining positive, and the exudative lesions, the protein is high. So with this diagnosis, we started treatment. As soon as the pericardiocentesis was done, the patient felt comfort, and anti-tuberculosis drug, 4-drug regimen was given as per the guideline of for a 5-year child weighing 14.5 kg. The patient was advised anti-tuberculosis treatment, that is in our national guideline. 3 FDC remaster 3 FDC. It is used in our national guideline policy. That is the rifampicin 75, isoniazid 50, and pyrazinamide 150 milligram. So 3 tablet once daily, and we also added ethambutol 100 milligram The patient weight is 15 kg, that is a 20 milligram per kg. So we need 300 milligram tablet. So one tablet 100 milligram, 3 tablet once daily. One of the important thing is that the ethambutol has side effect, like it causes optic neuritis. The patient is 5 years, so he can tell about the blurring of vision, about the loss of vision. So we suggested ethambutol 300 milligram tablet once daily, and the treatment this regimen is going on up to 2 months the initial phase, and the following but the 4 months the continuation phase. With the above regimen, the patient showed good result during the follow-up. The ESR is come down to the patient is getting well, and the pericardial fluid is become less, and the vegetation is gone. Echo finding after the treatment, there is no vegetation, almost absent. There is a minimal pericardial effusion, and the patient is getting well. So definitely it is a case of Mycobacterium tuberculosis affecting the pericardium and the endocarditis. So this is a Mycobacterium tuberculosis, Mycobacterium endocarditis, tuberculosis endocarditis. With this is my reference. Thank you. With this, thank you very much for patience hearing.
The Silicon Valley of India. So I've been honored to present in this session. So my topic is anomalous drainage of the left superior vena cava into the left atrium. So this is a case report. It was an interesting case that we came across. So I'm presenting that. Are my slides visible?
Yes, ma'am, they are visible.
Thank you. So I have no conflict of interest, and I have no financial disclosures to make. So we all know that there are the systemic venous connections and drainage can have anomalous. Am I audible?
Yes, you are audible.
Yes, you are. Thank you. So they may at times behave like right to left shunts, so causing cyanosis, paradoxical embolism, or even a stroke. So a persistent left superior vena cava is the most common anomaly, and it can occur in about 0.5% of the general population and in 4% of patients with congenital heart diseases. So association of unroofed coronary sinus with the persistent LSVC is a rare anomaly, and it was initially described by Raghib et al. In 1965. So it is very much incidentally detected because it doesn't have any symptoms per se. So our case was a 22-year-old female patient who was referred to us by the cardiologist with the partial atrioventricular canal defect. So ECG showed a complete heart block, and when we did the 2D echocardiography, there was a trifoliate left atrioventricular valve with mild regurgitation. On operating table, we saw that there was a good-sized right SVC, but there was no innominate vein. So on looking for an LSVC, we found that there was an LSVC. And apart from that, we found that the left pulmonary veins were draining into the LSVC. So here is a picture which shows there was this LSVC which was draining, and the pulmonary veins were draining into the LSVC. So LSVC was again opening into the left atrium. So it was opening onto the roof of the left atrium near the left atrial appendage. So here you can see the left atrial appendage. You can see the LSVC which is draining into the roof of the left atrium. And these are the small pulmonary veins. So and apart from this, patient also had an unroofed coronary sinus. So after arresting the heart with whole blood cardioplegia, we opened the right atrium and assessed the anatomy. So the left atrioventricular valve was repaired with interrupted 5O polypropylene sutures to abolish the mitral regurgitation which was present. And since there was a large ASD, atrial septal defect, which was almost converting the whole thing into a common atrium-like picture. So this was corrected by creating a septation using the native pericardium using 4O continuous polypropylene sutures. So then after this, LSVC was divided cranially, and the distal, so here you can see that the after division of the LSVC, we have suture closed the lower end of the LSVC, and the proximal part which was transected was anastomosed to the left pulmonary artery. So post-operatively, since the patient already had a complete heart block, in the post-operative period, we got a permanent pacemaker implanted, and after that, the patient was discharged. So after almost a month's time, when the patient came back to us, doing well, we got a CT scan done, which showed this kind of imaging. So we saw that the lower end, here you can see that the lower end of the LSVC, which was suture closed, then you can see these multiple pulmonary veins draining into this LSVC, and LSVC was opening into the left atrium. So LSVC, the part of the LSVC, a part of it, part of the LSVC was acting like a conduit, draining all the pulmonary venous blood into the left atrium. So coming to the LSVC per se. So as I said, only some 0.5% of the general population has a persistent LSVC. And it is usually because of the persistence of left anterior and left common cardinal veins. So here you can see a picture. So you can see that you have a left horn and right horn of the sinus venosus. So embryologically, if you remember, we have a sinus venosus which has two horns, that is the left and the right. So when there is persistence of this anterior cardinal vein and the common cardinal vein, it results in the presence of LSVC. Usually this part here you can see in the second picture that it gets abolished and it remains as ligament of Marshall. So when this persists, it results in LSVC. So this LSVC usually drains into the coronary sinus and most often doesn't create any kind of problem. Sometimes it can drain into the inferior vena cava, sometimes into the hepatic veins. And like in our case, sometimes it can also drain into the roof of the left atrium. So where it can cause some amount of slight desaturation as well as acting like a right to left shunt. So since there was an unroofed coronary sinus, so this was taken care of. And so when it drains into the left atrium, what happens is that it acts like a right to left shunt. So it can also cause paradoxical embolism, some brain abscess, or even stroke. So in majority of these cases, whenever there is an LSVC, the RSVC is also present, or sometimes the RSVC may be very small, diminutive, and the LSVC may be very large and draining majority of the venous blood. And usually in 65% of these cases, there is absence of the innominate vein. So diagnosis of this LSVC is usually made on transthoracic echocardiography showing a dilated coronary sinus, and this can also be confirmed with agitated saline contrast echocardiography. So as I said, most often it is an incidental finding in cardiovascular imaging or surgery. So LSVC with unroofed coronary sinus can be dealt with by ligating it when there is an adequate sized innominate vein as well as RSVC. So in such conditions, we don't have to worry much because the innominate vein will take care of whatever the drainage of venous volume was getting drained through the LSVC can be channeled into the innominate vein and then into the RSVC. So other alternative ways of dealing with this is that it can be divided and re-implanted. So where all can you re-implant it? You can re-implant into the right atrium, to the right superior vena cava, or even to the pulmonary artery. Like as in our case, we anastomosed it to the LPA, that is the left pulmonary artery. So in case the LSVC is very short, then we can use a interposition conduit to reach the appropriate pre-implantation sites as mentioned above. And also it is technically difficult to place in the presence of an LSVC. So what are the things it can, what are the kind of problems that it can create is that it is difficult to place the pacemaker leads, hemodialysis catheters or Swan-Ganz catheters whenever we have to, we are forced to catheterize the LSVC. Then LSVC is also associated with supraventricular tachycardias, atrial fibrillation, or even sudden deaths because of a possibility that sometimes it can irritate the coronary sinus where an ectopic pacemaker can be present. So this is again, as I said, only 0.5% of the general population is afflicted with this. So in that, a small chunk of people can be affected by these symptoms. So the take-home message is that whenever there is an LSVC, we have to make sure that our cannulation strategies have to be planned well in advance. We have to plan if there is a congenital case, then we have to assess the case preoperatively itself so that our decision and our strategy for appropriate surgical management is done much well in advance, rather than encountering a case like this where you have to make decisions as and when you're operating. So thank you. Thanks a lot for giving me this opportunity. Thanks, everyone.
Thank you, ma'am, for bringing
is on percutaneous implantation of pulmonary valve, analysis of cases in a Bangladeshi center. I have no disclosure. Now, prevalence of heart valve disease, if we see that all valve disease is the highest, mitral valve is 10%, aortic valve is 6%, and pulmonary valve replacement among the children, actually there is no percentage among the studies. So percutaneous pulmonary valve implantation was introduced in 2000 by Professor Philip Weinhofer to treat stenosis and regurgitation in a prosthetic conduit in the right ventricular outflow tract. Later, modification of the valve came, which are able to treat RBUT dysfunction, even in bare and dilated RBUT. Up to 2022, about 15,000 cases of PPBI was performed all over the world. RBUT dysfunction often encountered in post-operative cases of complex congenital heart disease like tetralogy of Fallot, truncus arteriosus, pulmonary atresia, double outlet right ventricle, transposition of great arteries, or post-Ross operation. This pulmonary valve replacement allow unobstructed forward flow of blood from the right ventricle to the pulmonary artery and thus control regurgitation. According to the perspective of Bangladesh, we are starting a pediatric cardiology program since 1998. Patients with complex heart diseases were referred to surgeons since then. In last 26 years, many of them came back with the complications of redo surgery or intervention. Most of the parents prefer percutaneous procedure rather than redo surgery. So this is one of our OPD data showing the number of cases who may require pulmonary valve replacement in future. Among them, tetralogy of Fallot in this period of 6 months is 397. Pulmonary atresia and BHD is 51. Double outlet right ventricle with PS is 21. Truncus arteriosus is 15. So all these patients will go to the surgeries and then in future they may need PPVI. So I am showing you our first case in 2012, which was the first ever case of South Asian region. So this was a 12 years old guard, tetralogy fellow with absent left pulmonary artery. He had ICR for tetralogy fellow in 2007. Again, he had redo surgery in 2009 for the pulmonary stenosis and RPA stenosis. But again, he developed severe pulmonary stenosis, and later we planned for pulmonary valve replacement in 2012. So this is the angiogram of this patient done first time, which is showing cleft and absent left pulmonary artery and RPA origin stenosis. After that, he went for the TOF repair, and then he came back and again he developed RPA stenosis. There was residual PSD, there was severe TR, severe PR. So there were a lot of problems again, and we sent him for redo surgery. After redo surgery with the conduit, he developed severe conduit stenosis with pressure gradient of 65 with calcification and free PR. So this time parents refused for surgery again, and we planned pulmonary valve implantation. Here we are seeing the RV angiogram, which is showing the severe conduit stenosis, calcification of the conduit, and there is post-stenotic dilatation of the right pulmonary artery. Now, balloon interrogation and coronary assessment was performed. We are seeing a balloon is implanted here, and simultaneously we are doing an aortogram to see whether there is any coronary compression or not. After that, we did the pre-standing with the two covered stand, because this conduit was completely calcified and there was chance of stand fracture in this kind of cases. So we have given two covered stand before implanting the valve stand. Now this is the melodic stent implantation with a 20 millimeter ensemble system. So this is the certificate from the Medtronic, where they announced that this is the first ever pulmonary valve implantation in South Asia. Now, what was the problem we faced? At that time, there was no cardiac MR in our country, so selection criteria was based only on the echocardiographic findings and CT angiogram. Finally, cardiac catheterization was performed to assess the RBOT by balloon occlusion technique, as well as to exclude coronary compression. Another problem was getting supply of the valves, accessories, and other hardware. And funding for the valve was also a problem. There is no insurance system available here, and parents of the patient have to bear the cost of the valve personally, which is not possible in our cases. Now, procedural challenge we faced were to train the cath lab staff, as this procedure is very infrequent, and maintaining the supply chain of the hardware is also a challenge. And about the supplier company, there is no local agent of the manufacturer in our country. Funding constraint is also there, infrequent procedures, so these companies are not also interested, and difficult to get supply of the valve accessories in time, and sometimes it is difficult to get multiple options for a single patient. So how we solve this problem? Fund collection we have tried from the charity and from the corporate social responsibility fund of various financial organizations. To avoid complications, we followed the strict inclusion criteria, and for different cases, for difficult cases actually, proctorial support was taken from Medtronic. So our policy was we accepted cases with the conduit function only, and many cases with transannular patch and native RBOT patch having severe PR. They also need PPVI, but we are preferring for them surgery till today. We use cover stent in all cases to create a safe landing zone and to avoid valve stent fracture. As valve was expensive, supply was limited, so strict selection criteria was followed to avoid the loss to any party by damaging the valve. So you can see the data where we are seeing that age in the patient is 9.5 plus minus 2.9 years, and mainly gender is female, 66%, male is only 33%. Height of the patients are 137 plus minus 17 centimeter, and age at the time of first surgery 4.2 years plus minus 2. Type of the conduits used are aortic homograph in 66% cases, pulmonary homograft in 16% cases, and bovine pericardial valve conduit in 16% cases. Primary diagnosis was tetralogy fellow in 33%, pulmonary atresia based in 66%. And about the number of surgeries in this series, British and industrial operation was performed in 66%, prof repair and redo surgery performed in 16%, and ICR top with RB2PA conduit due to LAD originated from RCA was in 2 patients, which is 16%. Now coming to the echo data, in most of the patients, the gradient was more than 45 millimeter of mercury, pulmonary stenosis gradient. And pulmonary regurgitation in most of the cases were moderate to severe. And RBUT diameter was around 20 millimeter in most of the cases. And RB and diastolic volume was from 130 to 160 ml per meter square. About PA size and PA anatomies, absent and LP was found in one case. RP-LP stenosis was found in few cases. And about the procedural data, all the procedures are performed under general anesthesia through transfemoral approach. And like CP stent and ENRA stent were used as pre-stenting before placing the valve in all the cases. And pulmonary valve replacement with melody ensemble used mostly were 18 millimeter. In one case, 22 millimeter ensemble, and in 2 cases, 20 millimeter ensembles were used. Device dislocation, device embolization was not encountered in any of the cases. There was no arrhythmia in any of the cases. About the immediate outcome, pulmonary stenosis gradient reduced from 50 to 10 millimeter, even to 0 millimeter in some of the cases, and p-value was 0.006, which is very significant. Pre-pulmonary valve regurgitation moderate to severe, and after valve placement it was none. So p-value was 0.005, which is also very significant. About the functional outcome of the series, P gradient across the pulmonary valve was 9.3 millimeter mercury. Pulmonary regurgitation was nil. There was trivial PR in only one case. Stent fracture was not seen in any of the cases, and infective endocarditis was seen in one of the cases. So now I am showing you the case number 10, which is the last case of this series. Here you are seeing that there is pulmonary valve stenosis in these cases, and gradient is very high, like about 70 millimeter mercury. This is the CT angiogram of the patient, and then the valve placement procedure. So this is the stent already placed, and now we are placing the valve. So this is the valve. And after valve placement, you are seeing there is no pulmonary regurgitation and no pulmonary stenosis. So we published this series in 2 of the journals. And in conclusion, I can say that percutaneous pulmonary valve implantation is an excellent treatment option in patients with acute dysfunction. Our result following PPVI had shown a significant reduction in right ventricular pressure and aortic gradient. The most common complication is stent fracture or PR in the context of endocarditis. Only one of our patients developed endocarditis, but no one had stent fracture. We got excellent result in our series. But having said this, we stopped this procedure for the financial crisis and lack of support from the companies. Thank you all for patient hearing.
Behavior of secondary school girls in rural and urban settings. Introduction. The increasing prevalence of unhealthy eating habits and sedentary lifestyles among adolescents, which often continues into adulthood, is a global public health problem. Many studies have so far addressed the nutritional status, dietary, and exercise behavior of the urban adolescents. But there are few studies which compare the nutritional status, dietary, and exercise behavior of the rural adolescent girls with those of urban adolescent girls. This study was aimed to make a comparative evaluation of food and exercise behavior of secondary school girls between rural and urban settings. Methodology. This cross-sectional analytical study was conducted in the Department of Community Medicine, Rajshahi Medical College, Rajshahi, over a period of 12 months from January 2019 to December 2019. The data were collected from 314 adolescent girls from 2 secondary girls of School of Kushtia, Bangladesh. Of the 314 girls, 140 were rural and 174 were urban residents. Students having known chronic diseases like valvular heart disease or any other systemic diseases that may affect their nutritional status absent on the day of interview who refused to participate in the study were excluded. Data were collected from the respondents using a semi-structured questionnaire containing the variables of interest. Results. The age of the respondents of secondary school girls ranged from 11 to 17 years, with mean age being nearly 14 years in both rural and urban cohorts. Urban adolescent girls were heavier than their rural counterparts. While urban adolescent girls used to skip rope more commonly, rural girls prefer riding a bicycle and running as outdoor exercises more often than the urban girls. 1/3 of the rural girls and 17% of the urban girls meet the World Health Organization criteria of physical activity or exercise. Rural girls frequently watch TV, while urban girls prefer playing games or surfing social media on mobile or computer as a pastime. Besides, the urban girls are more often fond of listening music, reading a book, and gardening compared to their rural counterparts, with majority of the urban girls spend more than 1 hour each day on mobile or TV or computer. About 90% of the urban girls used to having breakfast more or less regularly as compared to 77% of the rural girls. Practice of taking major meal more than 2 times a day was significantly higher in the rural group. However, taking light meals or snacks equal or more than 2 times a day, consuming milk, eggs, meat, and fruits in most of the days in a week were frequently practiced by the urban girls. Although intake of vegetables was almost identical between the groups, consumption of fruits was much higher in the urban girls than that of the rural girls. There was significant association between dietary habit and residence, with more than 55% of the rural adolescent girls having unhealthy dietary behavior as opposed to 41% of urban girls. The odds of having unhealthy dietary behavior were nearly twofold higher in rural girls than that in urban girls. Conclusion. The study concluded that urban adolescent girls are usually heavier than the rural girls. About 1 in 3 rural girls and 1 in 6 urban girls meet the World Health Organization criteria of physical exercise, suggesting that rural girls are more inclined to have good exercise behavior than do their urban counterparts. A significant association between dietary habit and residence is observed, with risk of having unhealthy dietary behavior in rural girls is nearly double than that of urban girls. Thank you. Thanks for hearing me out, and thank you again. Thank you so much.
Thank you. India. I'll be presenting on the study we conducted in our department on acute kidney injury following cardiac surgery, which will briefly discuss on the clinical outcomes along with preventive strategies over the decade. Next slide, please. So objectives of the study was to discuss the incidence and risk factors of AKI post-cardiac surgery, analyzing the short and long-term clinical outcomes associated with AKI, exploring preventive strategies and advancements in AKI management, and to evaluate the role of biomarkers in AKI prediction and diagnosis. Next slide. So, AKI is a prevalent complication after cardiac surgery, which significantly affects the patient's morbidity, mortality, and healthcare costs. And the condition, which is usually termed as CSA AKI, is characterized by abrupt kidney function decline, and it can be due to multiple factors such as reduced cardiac output, ischemic reperfusion injury, nephrotoxic agents, and systemic inflammatory responses. And despite all the advancements in surgical techniques and perioperative care, the incidence is still high, which necessitates a focus on risk stratification and preventive strategies. And the key definition for AKI, which includes all the criteria like Rifle, AKI, and KDIGO, has evolved over time, standardizing diagnosis due to the incidence level remaining very high. And next slide, please. Methodology of our study included a systematic search over databases such as PubMed, Google Scholar, and Scopus. Inclusion criteria were studies from 2000 to 2023, focusing on AKI preventive strategies. Exclusion criteria were non-English studies, abstracts, and animal studies. And quality of the studies were assessed individually using Downs and Black 27-point checklist. Next slide. So our study yielded that the clinical outcomes of AKI is characterized by increased short and long-term morbidity and mortality amongst the patient. And there's a higher likelihood of CKD development post-AKI and a prolonged hospital stays and increased healthcare cost, as well as elevated risk of death, particularly with renal replacement therapy. And the incidence of AKI post-cardiac surgery varied across studies due to differences in population. So over the years, definitions were modified based on the different criteria that were included. Initially, AKI was mainly based on whether the kidney function tests were applicable to the patient or whether they had any derangements or anything. But recently, a lot of definition improvisement has been occurring. And based on that, incidence as well as how to evaluate the incidence has also changed over the years. A meta-analysis conducted maybe 3 years ago highlighted that a 2 to 4 times increased risk of early mortality is seen among AKI patients post-cardiac surgery. And the risk factors identified were mainly comorbidities like diabetes, hypertension, hypercholesterolemia, reduced LVF, and elevated preoperative serum creatinine. Female gender and congestive heart failure also contributed wholly to increased vulnerability. Next slide. Preventive strategies that were mainly executed were pharmacological approaches, which include dexmedetomidine, cephiracin, and non-pharmacological approaches, which included renal guard system and KDIGO-based treatment bundle. So dexmedetomidine is actually a selective alpha-2 adrenergic receptor agonist, as all you know, and it's demonstrated to have neuroprotective and anti-inflammatory effects, which reduces AKI severity and improves outcomes during cardiac surgery. And the studies have shown that usage of dexmedetomidine has more importance than using other drugs like teprazoline or sodium bicarbonate and N-acetylcysteine. And studies show significant reduction in AKI incidence and severity with improvement in the recovery times also. So it's widely incorporated into perioperative care protocols. The next drug was teprazoline, which is a P2Y12 receptor antagonist, which is found to decrease AKI frequency and severity in high-risk population. And promising results have been suggested on a broader role in cardiac surgery prophylaxis. Coming to the less studied version, which actually we got as a result was sodium bicarbonate and N-acetylcysteine. And both are used to prevent contrast-induced nephropathy. And these agents have shown mixed results in CSA AKI, but remain in high consideration for high-risk group. So mainly it's based on dexmedetomidine and teprazoline, which is used mainly as part of pharmacological approach. And then when you come into non-pharmacological strategies, which will include renal guard system, which is an actual innovative system which maintains fluid balance and diuresis, reducing AKI by preventing renal hypoperfusion and nephrotoxin buildup. And efficacy rates based on international studies show a marked reduction in AKI rates during cardiac surgery and angiographic procedures. And the next treatment is KDIGO-based treatment bundle, which has components which includes optimized fluid management, avoidance of nephrotoxins, and early recognition of AKI using biomarkers. And on a global implementation level, which is widely adopted as a framework for AKI prevention in cardiac surgery patients. Along with this, ischemic preconditioning, goal-directed treatments are therapy have also been taken as approaches, and trials across Europe and Asia report consistent efficacy in reducing AKI severity in terms of ischemic preconditioning. And based on multiple international studies, highlight success in minimizing renal hypoperfusion and optimizing perioperative outcomes in goal-directed therapy. which is mainly by using personalized fluid and hemodynamic management. And according to our study, this was the efficacy rate, and among them, Cardiology bundle had 90% of efficacy, followed by dexamethasone at 85, teprazolam at 80, and renal guard system at 75%. The other therapies, as well as this N-acetylcysteine and sodium bicarbonate, were found to show around 20 to 40% efficacy. Next slide. So the limitations we found based on the four important approaches were dexmedetomidine showed requiring a careful dosing because in high amounts it is seen to show toxicity. In renal guard system, it was the high expensive and its high cost schedule. Then Cardiology treatment bundle showed implementation challenges, and in teprazolam was limited availability of the drugs across the place. Ma'am, next. So, on an international perspective, when you look into global insight on AKI prevention, studies from Europe mainly emphasize the integration of biomarker-guided risk stratification along with Cardiology bundle, leading to early detection as well as intervention. While North American studies prioritize pharmacological advancements like teprazolam and combination of dexamethasone with other anti-inflammatory agents, while Asian studies underscore the effectiveness of ischemic preconditioning and gold therapy in resource-constrained settings. So, towards a future direction or a future perspective of how the AKI could be controlled, biomarker validation has been an international consortium which aim to validate multi-marker panels to improve predictive accuracy. And there is personalized medicines, which is advancing in genomics and proteomics, which could lead to individualized AKI prevention strategies. And technology integration, where you can have AI-driven algorithms to predict AKI risk using real-time perioperative data, which enhances the decision-making. So coming to the role of biomarkers in AKI, it is mainly found with two, that is plasma NGAL, which is an early as well as sensitive marker, which is detectable up to 48 hours before a creatinine rise is understood. And a meta-analysis of 307 studies indicate that plasma NGAL is a highly sensitive and specific biomarker for early AKI detection, capable of identifying kidney injury up to 48 hours before a diagnostic rise in serum creatinine, which is a very highly important factor for cardiac surgeons as well as anyone who is working behind the scene in the OT theatre. So the clinical utility is its ability to detect AKI earlier, showing or allowing clinicians to implement timely intervention, potentially reducing AKI severity, and in certain cases, AKI could be completely prevented. The next one is a pulse wave velocity, which is shown in the graph, which is a non-invasive tool for predicting kidney disease progression mortality. And the relevance of this pulse wave velocity study comes when it provides a non-invasive method to assess the AKI risk factors. And a study conducted by Greenwood et al. Demonstrated that arterial stiffness measured via a pulse wave velocity predicts not only AKI progression, but also cardiovascular and all-cause mortality in patients with CKD. Next slide, ma'am. So the key findings of the study were dexmedetomidine and teprazolam showed promising renoprotective effects. Renal guard system and Cardiology bundles are effective non-pharmacological interventions for preventing CAC-AKI, and emphasis on importance of early detection and personalized preventive measures. And there's a long-term implication of AKI underlining the need for enhanced strategies. Next, ma'am. In the conclusion of the study is, AKI remains a critical concern post-cardiac surgery with significant impact on patient outcome. And preventive strategies, both pharmacological as well as non-pharmacological, are crucial for the mitigation. And further research and tailored interventions, highlighting on tailored interventions, are vital for optimizing care and reducing AKI burden following a post-cardiac surgery. Thank you. if anyone has any doubt.
Good day, colleagues. Let me present to your attention a report on the topic CT diagnostics of predictors of abdominal aortic aneurysm progression. One of the urgent problems of modern vascular surgery is to solve the issue of timely assessment and treatment of abdominal aortic aneurysm, which in progression leads to fatal outcome with a prevalence of 1.3% in patients of over 50 years, while in elderly men more than 12%. The most formidable complications of aneurysm is rupture, which leads to catastrophic consequences. 50% of patients die before admission to the hospital. Every minute mortality in these patients increased by 1%, and lethality in surgical interventions reaches up to 50%. Physical examination has poor sensitivity, less than 65%. Nearly 30% of aneurysm ruptures are misdiagnosed at initial presentation. Moreover, less than 25% of patients have the characteristic triad of symptoms of hypertension, abdominal pain, and pulsating mass in the abdomen. The main indicator for surgical treatment is its diameter, more than 5.5 centimeters in men and 5 centimeters in women, as well as increase in aneurysm diameter by more than 1 centimeter per year. To date, the degree of increase in aneurysm diameter is one of the main predictors of rupture. The risk of rupture is significantly higher in larger aneurysm. The approach based only on the assessment of aneurysm diameter doesn't provide an opportunity to prevent aneurysm rupture below the established threshold. At the same time, it's poorly reflected in the assessment of individual risk. When assessing progression, it's important to consider not only the diameter and the rate of its increase, but also other morphometric characteristics of aneurysm. Extent, contours, size of the wall thrombus, state of the wall thrombus structure, degree of wall calcification, size of the contrast lumen, wall tension. The search for new diagnostic methods, many different approaches have been studied, but they haven't yet been validated. In this regard, the current standard of surgical intervention for aneurysm is still based on the maximum diameter. Thus, the objective of our research is the determination of predictors of rupture and their thresholds for abdominal aortic aneurysm progression based on CT studies. CT studies of 70 patients with abdominal aortic aneurysm with different degrees of its dilation were included in the study. All images of CT studies were evaluated to detect potential risk factors of rupture and signs of rupture. For this purpose, all patients were divided into 3 groups depending on the changes of the aortic wall. Group 1 with stable aneurysm wall, Group 2 with unstable wall, and Group 3 with rupture. 5 signs of wall changes have been proposed on CT as markers of increased risk of rupture. First is crescent sign and thrombus fissuration sign. Focal wall heterogeneity of circular calcinates, aortic bulges or blebs, and draped aorta sign. These signs have different prognostic value and can be detected either separately or in combination. Aortic bulge on CT can be considered as focal bulges of the aneurysmal wall, corresponding to the sites of incomplete rupture. This sign histologically corresponds to inflammatory changes and focal thinning of elastic fibers associated with the impending rupture. The picture on the right shows aortic bleb, and 3 months later, an rupture has occurred. Another sign is the draped aorta, in which there is no clear boundary between the posterior wall of the aorta and the adjacent vertebrae. This is a consequence of disruption of the integrity of the aortic wall, which in turn can cause vertebral osteomalacia. That is, it's an area in which the posterior aortic wall is not discernible as a clear line. The posterior aortic wall follows the contour of the spine on one or both sides. Early detection of abdominal aortic aneurysm ruptures is of particular importance. The most characteristic localization of rupture is the posterolateral side, in which hemorrhage splits into the retroperitoneal space. In contrast, rupture of the anterior and anterolateral wall of the aorta can lead to intra-abdominal hemorrhage, in which the lethal outcome is more rapid. The most important clinical symptom suggestive of aneurysm rupture is the sudden onset of pain syndrome. CT studies were performed in 2 stages, which included contrast-free study and arterial phases of contrasting. Scanning area, upper boundary to diaphragm level, lower boundary bosom articulation. Scanning and image reconstruction parameters are presented on this slide, and let me not dwell on them. The following parameters were determined in patients of each group at different levels. The proximal aneurysm next, level of maximal aneurysm expansion, at the level of the terminal aortic section. Maximum aneurysm diameter, maximum lumen diameter, maximum wall thickness with a mural thrombus area at the level of maximal dilation, lumen area, wall area with wall thrombosis at the level of maximal dilation, aneurysm extent, the ratio of the diameter of the aneurysm and the diameter of the aorta at the diaphragm level, the ratio of thrombosis area to aneurysm area at the level of maximal dilation, aortic wall stress, the degrees of calcification of the aneurysm, and separately the whole abdominal aorta. The maximum aneurysm diameter was measured perpendicular to the middle line of the lumen in multiplanar reconstruction. The cross-sectional area of the vessel, lumen area, and the area of wall thrombus were measured at the same location. Thrombus area was defined as the difference between total vessel area and lumen area. The refraction of aneurysm thrombosis was defined as the ratio of the area of wall with thrombosis to the total vessel area. Aneurysm length was defined as the distance from the distal end of the proximal neck of the aneurysm to the proximal end of the distal neck, or in absence of the distal neck to the bifurcation level. For our study, we used the modified Adolescent scale. Calcium index was determined by cumulative assessment of the abdominal aorta along its entire length from the level of the diaphragm to its bifurcation, as well as along the aneurysmal segment separately. The wall stress was measured using the following formula. Progressive 35% increase in aneurysm area can be considered a precursor to CT signs of wall instability, and at 2.9 a progressive 35% increase in aneurysm area can be considered a precursor to CT signs of wall instability. and the 2.9-fold increase in area compared with the stable wall leads to aneurysm rupture. When comparing rates between groups, it appeared that while aneurysm area increased in each group, aneurysm luminal area significantly began to increase only before rupture. A 1.7-fold increase in lumen area compared to the stable wall led to aneurysm rupture. As the size of aneurysm increased, there was a gradual increase in the wall area with thrombus. The thrombus area was 9.9 square centimeter in the group with a stable aneurysm, 20.5 square centimeter in the group with unstable wall, and 48.1 square centimeter in the group with rupture, respectively, with significant differences between groups. Thus, a 2.1-fold increase in wall area compared to a stable wall leads to its instability, and a 4.8-fold increase leads to rupture. The progression of an infrarenal aneurysm leads not only to an increase in its diameter, but also in its length. In the group with a stable aneurysm, the length was 88 millimeters. In the group with an unstable aneurysm, 101 millimeters. And in the group with a rupture, 136 millimeters. It should be noted that significant differences were found between groups 2 and 3, as well as between groups 1 and 3, which indicated that the increase in its extent is observed closer to rupture, and its increase 1.55 times compared to stable aneurysm. Moreover, there was an increase not only in the extent but also in the vessel area and lumen of the proximal neck and terminal aorta. The ratio of diameter of the infrarenal aneurysm to the diameter at the level of the diaphragm is of clinical importance, since the size of the aorta at the level of diaphragm is more stable. In addition, it allows to exclude individual peculiarities of aneurysm size. In case of unstable wall, this ratio amounted to 2.3, and in case of rupture, 2.9. That is accompanied by an increase of 1.63 times. An increase in the relative area of wall thrombosis occurs only during the formation of an unstable aneurysm. Further aneurysm progression, although accompanied by an increase in the size of thrombosis, but without an increase in this ratio. The relative area of wall thrombosis during its destabilization increased by 23%, amount to 72%, and remains approximately at this level during rupture. It's possible that thrombosis during early wall destabilization prevents rupture but doesn't prevent aneurysm progression. According to our study, an increase in aneurysmal wall tension is accompanied by the appearance of CT criteria of its instability. Further progression of aneurysm leads to a significant increase in tension. The wall stress score was 463 in the stable aneurysm group, 594 in the unstable group, and 735 in the rupture group. Of note, wall stress correlated not only with aneurysm size but also with wall thickness and wall area without thrombus. With thrombus. In our study, there were no significant correlations of the degree of aneurysm calcification with area and size. High correlation coefficient was found only between the degree of calcification of the entire abdominal aorta on the aneurysmal segment. Moreover, there were no significant differences in the degree of calcification of the wall of either the abdominal aorta or the aneurysmal segment when comparing perimeters in different groups of patients. Nevertheless, the results obtained draw attention to a sharp increase in degree of calcification of the abdominal aorta and aneurysmal segment closer to rupture, which can be considered as a predictor of aneurysm rupture. The non-significant differences between the groups can be explained by the large variation the indicators. According to the results of the study, we can assume that the mechanism of aneurysm progression are caused not by the degree of calcinosis but by the severity of the general degenerative inflammatory process in the arterial wall. Work analysis revealed unstable wall thresholds. First, maximum aneurysm size 58 millimeters, aneurysm area 24.5 square centimeters, wall area 15.4 square centimeters, ratio of aneurysm diameter to normal aortic diameter 1.9, stress 512, wall with thrombosis to aneurysm area ratio of 66%. Analysis of the proximal neck and terminal part of the aneurysm showed no significant changes compared to the stable wall. The threshold values for detecting CT signs of rupture, according to rock analysis, at the level of the proximal neck can be considered to be vessel area of 5.7 square centimeters, lumen area of 4.1, and maximum diameter of 28.3 millimeters. The threshold values for maximum infrarenal aneurysm size were 7.6 centimeters, area 34 square centimeters, wall area 17 square centimeters, and extent is 132 millimeters. Dilation of the terminal portion of the aneurysm can also be considered a predictor of aortic aneurysm rupture. In this patient, the increase of the terminal section are 2.75 times, wall area 4.5 times, and lumen area 2.1 times was revealed. At aortic aneurysm rupture, according to rock analysis, the threshold value in the terminal section of the vessel area is 14.7 square centimeters. Wall area is 7. Maximum thrombosis thickness is 11.9 millimeters. The ratios of aneurysm diameter to normal aortic size at the diaphragm level are 2.3. Stress is 611 Newton per square meters, and the ratio of wall with thrombosis area to aneurysm area is 76%. Multivariate logistic regression analysis was performed to identify the most significant predictors. If the ratio of aneurysm diameter to normal aortic diameter increased by 1, and the chains of CT signs of wall instability increase 24 times, and if the thrombus per aneurysm ratio increased by 1 unit, the changes of CT signs of wall instability increase 1.07 times. To identify the most significant predictors, multivariate logistic progression analysis was performed, which resulted in the development of prognostic model to determine the probability of CT signs of aneurysm rupture, depending on the above-mentioned predictors. If the area of the proximal neck lumen increased by 1 square centimeter, the chance of CT signs of aneurysm rupture increased by 1.8 times. If the area of the aneurysm wall with thrombus increased by 1 square centimeters, the chance of CT signs of aneurysm rupture increased by 1.2 times. So, the main morphometric criteria for aneurysm progression are diameter and cross-sectional area of the aneurysm, lumen area, wall area, including mural thrombus, length of the aneurysm, the ratio of the aneurysm diameter to the normal aortic diameter at the level of the diameter, ratio of the area of the wall with a mural thrombus to the area of the aneurysm at the level of maximum expansion, aneurysm wall tension. The threshold values of CT criteria of instability were determined: 1.2-fold and 1.4-fold increase in aneurysm diameter and cross-sectional area, with threshold value of 58 millimeters and 24 square centimeters respectively; 2.1-fold increase in aneurysm wall area with mural thrombus, with a threshold value of 15.4 square centimeters. Increase in the ratio of aneurysm diameter to normal diameter by 1.3 times, with a threshold value of 1.9. Increase in the ratio of wall area with mural thrombus of aneurysm area by 1.25 times, with the threshold for a value of 66%. Increase in wall stress by 1.3 times, with threshold value of 512 Newton per square meters. The threshold value of CT criteria of aneurysm rupture were determined also: 1.7-fold and 2.9-fold increase in diameter and cross-sectional area, with threshold values of 76 millimeters and 34 square centimeters respectively. 4.8-fold increase in aneurysm wall area with mural thrombus, with a threshold value of 70 square centimeters. Increased in the ratio of aneurysm diameter to normal aortic diameter, 1.6-fold, with the threshold values of 2.3. Increase in wall stress, 1.6-fold, with a threshold value of 611 Newton per square meter. Increase in aneurysm length, 1.6-fold, with a threshold value of 132 millimeters. Increase in proximal neck area, 1.5-fold, with a threshold value of 5.7 square centimeters. Prognostic CT signs of aneurysm instability are an increase in the ratio of the aortic aneurysm diameter to the normal aortic diameter by 1, which increased the likelihood of wall instability by 24.3 times, and increase in the thrombus per aneurysm ratio by 1 increased the probability of wall instability by 1.1 times. Prognostic CT signs of aneurysm rupture are an increase in the lumen area of the proximal neck by 1 square centimeter, which increased the probability of aneurysm rupture by 1.48 times, and increased in the area of the aneurysm wall with a mural thrombus by 1 square centimeter, increase the probability of an aneurysm rupture by 1.2 times. Thank you for your attention.
Professor in Department of Pharmacy, College of Pharmacy. So if you are going to see the overview of my study, introduction of this literature review, arrangement objectives, plan of work, materials, methods, methodology, results in discussion, some conclusion responses. So we are dealing with the condition of nephrolithiasis with renal calculi or kidney stones. So that is due to super saturation of the urine, especially in the kidney area. So it may be a time, maybe a stag on stones also. It will be a global problem. Only 12% of the population is getting affected by this. And mostly it is present with more incidence in South India. So geographic location will be the main reason, and the dietary habits also. In even India, if you are going to see around 15% of the population is affected by the renal stones. Maybe the climatic conditions, that is, especially in Kerala, if you are going to see it will be hot and humid, and that is going to be the main reason is nephrolithiasis. If you are going to see the categorization, these are the photos you can see. Maybe the oxalates or calcium forms, those will be from majorly if you are going to see. And maybe location, if you are going to see, maybe in the pelvic region or maybe in the index also. Regarding our study, we are going to see. But it will be a complex factor for stone formation. Major ones may be the hyperuricemia or hyperparathyroidism organ problems, and recurrent infection, especially urinary tract infection, or oxalic acids presence, urine hyperoxaluria, hyperuricosuriaria, or too much of the sugar salt in the diet, or maybe obese conditions, little or too much or little size, your family history, or medical conditions like Crohn's disease or type 2 diabetes, or dehydration. It may be the main reason for the nephrolithiasis. We are going for the need for the study. The nephrolithiasis may be the cause mainly of the first episode, and there is a more risk of the recurrence after the first episode. So only 20% of the patients they are having the second incidence. So mainly the risk factors, or they are not having the knowledge. Patients are not having the knowledge or awareness about this, and that is our pharmacists educate or do the basis. And that is the main priority. So if you are doing the patient counseling, there is chance of the preventing the recurrence of this nephrolithiasis. So that is main idea. See here. So regarding the etiological factors and about the risk factors, we are going to counseling about the patients, and that is going to help the patients. Some of the literature review we are going to see for this nephrolithiasis. So the scientist Dye is concluded study 2002. So we are going to see the more fluid intake that is going to prevent this, and some of the diet like tea, must avoid the tea also, and increased sodium consumption and oxalate containing foods, more consumption of this is going to be the risk factor of this nephrolithiasis, and higher amount of the polyunsaturated unsaturated fatty acids also. Again, the Ferraro PM, it also they have studied. So in case of the preventing, in case of this nephrolithiasis, more consumption of vegetable and fruits that is going to help. So diet regarding vegetarian, non-vegetarian is not going to be any difference. Most of the vegetables also is causing this nephrolithiasis conditions. So aim of the study is going to determine the impact of patient counseling and education on the prevention of the recurrence and severity of the nephrolithiasis in our patients. The objective is going to determine the prevalence of the renal calculi in all patients, analyze the etiological aspects of the renal calculi, identify number of stones or type of stones, and where it is stones are present in the kidney, that is going to be analyzed. And where the treatment is going to be followed in the nephrolithiasis. Renal colic, that is a pain that is going to encounter, that is calculated by the NRS11 pain scale, and comparing the effectiveness of the drug killer like diclofenac and tramadol for managing the acute urinary colic and the impact of the patient counseling education on the prevention of the recurrence and severity of the nephrolithiasis and patients. These are the objectives of the study. The plan of work is going to be hypothesis generation, literature review of the studies, we are trying protocol preparation. And before going to the study, we are getting the patient consent form. So that is going to be very important in our trials. We are going to go with the consent from the patient. That is going to be very important. And regarding the patient, we are giving some information by providing the leaflets also in the local language. And we are preparing the data entry form and the approval from the institution human ethics committee approval from the hospital we have got. And phase 3 is going to be the recruitment of the patients, collection of the details from the patients, follow-up of the patients, data compilation and analysis and statistical data to validate the null hypothesis. So the things we have done. And study design is a study done in the prospective international study that is done in the surgery, urology and casualty department in Nirmala Medical Center in Wiryaputra, Kerala. And regarding material methods, we have got the human ethics committee approval. And study criteria, our patients who are diagnosed with the renal calculi confirmed by the hematuria and the scan of the abdomen are selected from 18 to 70 years. And patient consent is going to be very important, and that is going to be the criteria. Exclusion is going to be those are having the problems like hepatic problems, cardiovascular, cerebral, stage renal disease, and the type of patients are going to be excluded from the studies. And the pregnant AIDS patient also, they are excluded from the studies. And hypothesis is going to be the first one is the patient counseling has no effect in decreasing the severity and recurrence of psoriasis. And dietary factors, lifestyle, and social habits have no impact on the corruption and recurrence of stones. Another is the both diclofenac and tramadol are having similar pain relieving effect. Patients having the pain colon. So these hypotheses are going to be false and is going to be proved by statistical design of null hypothesis. And all these are going to be false. The sample size you can see based on the literature study we have calculated and we have fixed as the 645 for patients. 2 test groups are created, each having the size requirement of 645 totally. So you can see the total patients are going to be 1,290 patients are studied. So that is the sample size. So patients with confirmed nephrolithiasis included, so that is going to be the inclusion criteria. The included patients are divided into groups, test 1 and test 2. In test 1, their counseling was done, patient counseling was done. In test 2 patients, they were not of counseling or education. The control group, so they are got the informed consent form, and that is they are free from the nephrolithiasis condition. So they are going to be the control groups. So all the details that is going to be the main reason for the nephrolithiasis. The data are collected, mainly dietary components and foods used like tomato, spinach, tea, coffee, egg, colocasia, yam, brinjal, grapes, red meat, chicken, seafood, humid. So all these are going to be there for raising this nephrolithiasis condition. So information was collected from the test and the control groups, and family history details also was collected, and fluid usage about the patients categorized as less than 2 liters, 2 to 4 liters, and 4 liters are also obtained from the patients. The risk factors that is for the chance of the nephrolithiasis, like alcohol, cigarette smoking, obesity, and exercise status are also collected from the patients. So renal colic, that is the pain that is experienced by the patients, and based on that scale, 11 scores. That is the numerical pain rating, numerical rating scale of till 11 scores was got from the patients. So based on the severity, so if you are having 0 means they are not having pain, they are having 5 means they are having the moderate pain. If they are rating as 10 means they are having a severe pain. So based on the NRS scale, we have determined the pain they are having. So the pain is going to be a major diagnostic thing. The patient usually comes with pain. That is going to be the first symptom they are going to say, and they are going to find out. We are going to find out the pain scale by using this numeric NRS method. So 40,290 patients are included. So test mass, we are releasing the test 1 and test 2. They are separated. Test 1 receiving the counseling and test 2 not receiving the counseling. So that was the studies. So based on the age group, we are going to categorize. So normally you can see the complaints normally come from the age of 51 to 60. So they are having increased incidence of this nephrolithiasis. So there's this result of the Fine, etc. That is the scientists who have reported that urolithiasis increases with the age, with peak distribution occurring in the age of 50 to 70 years. So according to our studies we have done, so mean you have got SPP, and you can see the incidence also was more at the age of 51 to 60. So prevalence based on the gender as per the scientist of the stomatology. From their study reports, urolithiasis increases with the age and is more prevalent in men. So we are also got the ratio here as 59% of the male patients encounter this nephrolithiasis, and more in case of the male. So that is the conclusion we have got. Based on the previous history of the nephrolithiasis, so it is very, once they have reported the nephrolithiasis, that is going to be recurring again and again. Especially you can see the percentage is going to be around 74 in this previous history of nephrolithiasis, and number of episodes you can see. Normally they are getting one number of episodes. One is going to be having a greater, that is around 57.34%. Here, the period between last confirmed episode. Normally the year one, within a year they are going to report again the nephrolithiasis is going to be recurring, especially within the range of more, see in case of 7 to 12 months, more occurrences there. Again, the family, so you can see the more percentage in case of the 70%. are going to see the family history going to be a major risk factor. Majority of the patients, nearly 70%, as per the scientist of Coincidentally, there is going to be a positive family history of the nephrolithiasis that can nephrolithiasis formation, especially in the younger ages. So fluid intake, and that is going to be a comparison. As per the scientist Gamage, they reported that the formation of stones in the kidney and the lack of fluid intake, that is going to remain saturation of the minerals or urine, and that is going to cause the nephrolithiasis. So you can see the result here. The fluid intake is going to be the main reason. Again, the dietary risk factor that is associated with this nephrolithiasis. So in this study, we have done the statistical analysis and determined the p-value also. So in this recording, you can see the spinach and the colocasia. So they are going to, and again the tea and coffee also. So they are going to form the major risk factor here, even though the other food items are mentioned. So they are not having a greater risk because they are less than 0.001. So that is very less value of P, and they are having a decreased risk factor. So compared with the spinach, you can see the tea and coffee and the colocasia. So they are going to be having again this diet is going to produce a great risk factor for the nephrolithiasis. And here also you can see the chicken also going to show a less incident risk factor for this nephrolithiasis compared to the grapes, red meat, seafood, and cashew nut. So this is going to have a less incident compared to the other parameters, other diets. Lifestyle risk factors are going to be there, and that is also going to be a major reason here we are going to see. All these are going to be a greater risk factor, especially for the alcohol and the cigarette smoking. There is going to be a more chance for the patients having this nephrolithiasis. And this comorbidities associated with nephrolithiasis. So if you are going to see the percentage, you can see the type 2 diabetes mellitus and hypertension, the combination of this and hypertension also, that is showing a greater percentage of these comorbidities, especially associated with the nephrolithiasis. So we can analyzing the patients, you can see they are having around 70% patients, 55.97% are having either diabetes or a combination of this hypertension and the diabetes. So there is going to be a direct association between the nephrolithiasis and the hypertension or the diabetes also. So that is the conclusion we have taken. So all the types of stones, you can see this calcium oxalate is going to be the majority of the stones are formed by the calcium oxalate only. Next comes the uric acid, steroid, and cysteine. So that is actually in case of the Indian patients, as per the scientists of Goa and all, also reports that the predominant type of stone in Indian population is going to be the calcium phosphate or calcium oxalate cells. And that is confirmed with the studies also. Location of studies, you can see majority is present in the kidney only. And next comes the ureter. Next location is going to be the pelvic respiratory junction, the pelvic ureter, and next the bladder. So as per the reports of the Alliance, is confirmed that renal stones reveals kidney as the predominant location of the stones. That is confirmed with our studies also. So as per the size of the stones, you can see the largest stone is going to be in the range of 11 to 15 millimeter. That is the largest stone. That is, and compared to that, next comes the 5 to 10 meter. And next is going to be the 16. And around 9 patients of less than greater than 20 and less than 5 millimeter, around 83 patients. So previous studies correct by reveals that stone size of 0.5 millimeter are easily passed out through the urine in most of the cases. And that is the size range is going to be more around 11 to 15 millimeter. Majority of the patients are having this large stones. The number of stones you can see. Normally, 2 to 4 stones is going to be there. Majority of the patients, they are having around number of stones up to 4 stones. And that is done by our studies as confirmed by our scientists of Ferraro reported that an average of 2 to 4 stones are formed majority of the nephrolithiasis patients. So majority of the patients you can see they are having this urinary tract infections. So they are having this nephrolithiasis. So they are having a decline in their kidney function as per assessment with their glomerular filtration rate. And they are suffering with the urinary tract infections also. And with the progression, they are also found that there is increase in the serum creatinine levels also. So regarding the majority of the patients, the antibiotics has been used for the treatment. Mainly, they are using cefpoarizone and sulbactam. Sulbactam are going to be, as per the prescription analysis, they have found out that these drugs are going to be frequently prescribed. Around 48% are going to be cefpoarizone and sulbactam is going to be prescribed. Next comes the ciprofloxacin, and next is going to be the chlorothiazide. That's going to be the treatment plan. The treatment plan. So what are they? Mainly they are going for the surgery, retrograde intrarenal surgery. So that is going to be common practice. That is going to be the main treatment for the nephrolithiasis, as confirmed by our scientist Zhu. It also reports that RIR is the preferred management option for kidney stones. So it is going to be very safe also. So most of the doctors, they are going to prefer for this RIR surgery. And next is going to be the percutaneous nephrolithotomy, PCNL. And another one is the ESWL method. The pain conditions we are going to see. The majority, they are having this pain. So mainly for management of the pain, they are using the drug that is diclofenac and the tramadol are going to be commonly used drugs. So based on the NRS 11 questionnaire, the severity of the pain was assessed. So you can see so mild before administration and after administration of the diclofenac, and before administration of the tramadol and the after administration of the tramadol. So you can see the condition. So both drugs are going to be equally effective in treatment of the mild to moderate and severe pain of the literally colic pain of the patients. So there's a diclofenac sodium we are going to see. The p-value or the mean difference, you can see that is less than 0.001, that is going to be highly effective. A statistically significant method are going to be followed. The NRS questionnaire also, based on that, we have decided that diclofenac sodium is having p-value is going to be very less, and that is going to be helping the decreasing the pain as the You can see the comparison based on the one-way ANOVA studies. The p-value is going to be found to be less than 0.001, indicating that both the diclofenac sodium treated group are going to be highly effective compared to the tramadol group. So based on the statistical analysis, so both are equally effective, but based on the ANOVA studies, further one-way ANOVA studies has been done. Based on that, we have calculated that this diclofenac sodium is going to be further more effective compared to the tramadol. So recurrence that is going to be there. So most recurrence we are going to see in case of the test 1 patients. More number of recurrence has to be reported. There is the second follow-up. Also, we can see the recurrence is going to be there. The recurrence is going to be observed in test 1 and test 2 groups also. And the third follow-up, also you can see the recurrence is going to be there for the patients. What is the test you are doing for the patient counseling? So normally you can see the patient counseling is going to be effective only after 1.5 years. Still that there is no much change to see for the p-value. There is no much change between the test 1 and test 2 group. The test 1 group, they have got the patient counseling, whereas test 2 group, they are not receiving patient counseling. So initially there is no change till the 12 months. And after that, you can see after the 1.5 years, you can see some change is seen, and you are going to see it's going to be effective. Patient counseling is going to be effective, especially after a long term, especially after 1.5 years. So they are trying, the patients have followed the schedule, or they have followed the counseling methods, and based on that, you can see the reduction in the percentage of the recurrence of the nephrolithiasis. So that is the confirmation we have got. So that is the report that is going to be there here. So there is going to be a reduction in nephrolithiasis, test 1, apart from test 2, norm, mainly after the 1.5 years to 2 years, we are going to see the results. So further follow-up studies, we have seen that the recurrence is going to be very much minimized in case of the patients. So this is the summary of the studies what we have done. What is the, so out of 1,290 patients, 645 patients are enrolled in test 1 and test 2. Test 1 have received the patient counseling and test 2 does not receive the patient counseling. So the study population age is going to be 51 to 60 years. So nearly 74% they have the previous history of nephrolithiasis, and 70% they have had the family history of the stones. The test group they have taken a less fluid intake, and there is more chance for the nephrolithiasis. That is one reason. Majorly, you can see the food items. Normally, mainly this tea, coffee, and spinach and chicken. There is no significant results with these foods. So alcohol also, you can see the usage of alcohol and cigarette smoking, obesity are going to be the major reason. And there is no significant association with exercise status in the nephrolithiasis patients. And diabetes is going to be the important comorbidity, followed by this hypertension also, both having a higher incidence of 51%. So most of the stones is going to be the calcium origin. A majority of the patients having stones, mainly having in the ureter, and that is the location. Normally having the size, the prevalent stone, size of the stone is going to be having 11 to 15 millimeter. That is going to be the size of the stones. Major complications the patients they are got is those are having this nephrolithiasis, they have got the urinary tract infection or the CKD. A major antibiotic use is going to be sulfasalazine or sulbactam for the treatment. And normal surgery procedure we are following is going to be retrograde intrarenal surgery. So that is going to be the most common surgery practice they are following. In most of the patients, they are admitted in the emergency department, and both the diclofenac and tramadol is going to be commonly used. In which we have compared and found out that diclofenac sodium is going to be highly effective comparator of the tramadol. So regarding the patient counseling, so initially we are not found any changes, but after 18-month period and 2 years, we have found that is the patient counseling groups are showing a significantly decreased recurrence of the urinary stone. So that is the conclusion we have done. So this is about the conclusions. So that is we have already discussed the risk factors we have discussed, and about the group separation of the groups we have discussed, and about size of the range of the stones, about 5 to 15 millimeter, and surgery methods or RIRS is going to be commonly used, and major complications is going to be the CKD disease that is going to be commonly found in case of these patients. I think we have seen already. So urinary colic, the pain is going to be a major symptom of the renal stone. So majority of the patients, they report of the pain, and majority they have come to the department. And we can see the diclofenac sodium is going to be the better treatment strategy for the compared to tramadol. The recurrence of nephrology is very high, 12% of the first year. It will be second. That is the conclusion we have got. And individualized patient counseling was found to be reducing the recurrence of the symptoms of the renal stones in study participants. So that is the conclusion we have got. The references. Thank you.
The degree degree of damage to the coronary artery in ischemic heart diseases doesn't always correspond to functional disorders of the myocardium. An individual approach to each patient is required to correlate the lesion of the coronary artery with the degree and size of the ischemic myocardium. It's also necessary to assess the pacification of various segments in the formation of common integral left ventricular function in order to determine the difference, or conversely, the degree of compensation for ischemic and unaffected zones. Having an extremely complete understanding for above, it becomes possible to maximize the use of the reserve potential of the myocardium. This work will demonstrate a new way to determine quantitative indicators of left ventricular myocardial pumping capacity, namely the volume in milliliter of various sections of the heart muscle. The modern vision of the state of the cardiovascular system is in a central sense dictated by methodological requirements and cannot be a fully informative source for the researcher. And it's also advice that's not convincing for any doctor to conduct the work of an intact heart in isolation, relying only on ejection fraction or another indicator. The moderate artificiality of various diagnostic methods doesn't bypass any branch of medicine. Also, it's of course the only real way to diagnose and treat diseases early. Any method of imaging the heart is closely related to the shortening of myocytes. The latter, in turn, is always the result of the voltage-load ratio. It follows that the deformation depends on the load. Any change in volume should be accompanied by a change in the length of the muscle fiber. So let's say that an increase in volume in the distal phase should be accompanied by an elongination of muscle fibers and vice versa in the systole phase. Thus, the deformation is closely related to the volume parameters, according to the laws of physics. And we know that the heart is a complex multi-parametric three-dimensional object that changes dynamically, which is one of the explanations for the above. The current echocardiography approach to assess the functional state of the myocardium is specifically aimed at studying the validation of the movement of the wall of the heart muscle with the measurement of deformation indicators in various directions, which are detected before change in the contractility function of the left ventricular wall. However, their criteria are an integral component of the complex mechanism of the cardiac cycle in the physiological sense, which is not denoted by the developments of the techniques themselves. Any method of calculating the left ventricular cavity is based on a model with the variable radius of curvature. Accordingly, the obtained volume of different left ventricular sites will not be similar, which determines the different stress of the valves due to the load failing on them, and the corresponding stretch of the myocardial fibers, which is known to require up to a threshold value beyond which the development of force is not possible. At the same time, the maintenance of the minimum required left ventricular lever in coronary heart diseases occurs due to a compensatory increase in the contractility function of intact myocardial segments by increasing the volume of left ventricular. This means that the accuracy in determining the volumetric parameters of the left ventricular cavity determines the reliability of the calculation results obtained. The main task of the cardiovascular system is to ensure and deliver the proper volume of blood to organs. Therefore, stroke volume is the resulting component of the main function of the heart. Having the opportunity to evaluate the stroke volume of various left ventricular segments and the proportion of their contribution of the formation of the total stroke emission, it becomes possible to determine the ejection fraction of their segments. In conditions of increased perfusion, it is possible to quantify the capabilities of each segment in comparison with the initial data equality obtained, which makes it possible to quantify the prospect of planned surgical intervention. So, the Philips ultrasound system was used to analyze the segmental function of the left ventricular myocardium. The study was conducted in 2B mode. The scheme of dividing the ventricular cavity into 5 segments according to the Hood et al. Method, where the lung excised L is the line drawn from the middle of the aortic valve to the tip of the left ventricular, and subsequent division of the left ventricular cavity will be explained in details a little further. According to the second Pope-Goldin theorem, the volume of a segment is defined as the volume formed by rotating the area of the corresponding segment around the lung axis of the heart by 180 degrees, with the center of rotation C located in the middle of the L axis. It can be seen from the formula that C is the area of the flat figure and D is the distance from its center of gravity to the axis of rotation. That's why it's necessary to determine the center of gravity of the figure under study, which is a very time-consuming process and unjustified from a practical point of view. The technical solution of this problem is as follows. So, since we have determined a 4-chamber position for operation accordingly, the lung excised L will be carried out throughout the middle of the mitral valve to the apex. Next, paper drawings of the circled contours of the left ventricular systole and diastole of one cardiac cycle and compared at the reference point C, which is the middle of the long axis of the left ventricular. Lines are drawn from the lateral edges of the mitral valve to the reference point C with the formation of a figure that will be the residual volume, and remaining zone outside the residual volume is divided into 5 equal parts at the corners, further designated by the concept of segments. Along the lung axis of the heart, the left ventricular cavity was visually cut into systole and diastole, and its mirrored reflection was complete in each half, followed by division by the above method into 5 segments, equivalent in agial. As a result, we obtain 2 mirror diastole patterns and 2 mirror systole patterns. The Simpson's method evaluates the following indicators: the end diastolic volume, the end systolic volume, stroke volume, and ejection fraction. First, the entire volume of the studied figure is measured by the Simpson's method. Next, the measurement of the figure formed by the mirrored half of the residual volume and the third segment of the diastole using the Simpson's method. Half of the result is a real contribution of this side to the total impact volume of the left ventriculum. Measurement of the figure formed by the mirrored half of the residual volume and the fifth segment of the diastole, and the motion of residual volume is subtracted from the resulting indicator. Half of the result obtained is the real contribution of this segment. Measurement by the Simpson's method of the figure formed by rotation for the first segment is not possible because the figure acquires an irregular shape from a physical point of view. However, the deduction method can solve this problem, namely the volumes of the third segment and the figures of the fifth segment with the remaining volume and summed up with the figure subtracted from the total volume of the entire figure. Half of the result obtained is the real specific contribution of the first segments. In this way, the results of the 2 systole figures and 2 diastole figures are obtained. Thus, the Simpson's method obtained the following data: end diastolic volume general, end systolic volume general, stroke volume general, ejection fraction general, end diastolic volume segment, end systolic volume segment, stroke volume segment, ejection fraction segment. Therefore, it's possible to quantify the share of the contribution of each segment to the formation of the general function of the heart according to the formula. When the difference between end diastolic volume segment and end systolic volume segment much is divided into end diastolic volume general. All studies were carried out initially with the deduction of the residual volume from the end diastolic volume and end systolic volume, respectively. The indicators of myocardial injection capacity are slightly higher than the initial ones from the anamnesis. And so let's imagine there are acceptable indicators of the end diastolic volume and end systolic volume standards for all 5 segments in our proposed way. Then it becomes possible to obtain the proper ejection fraction of each segment. We found a control group of 26 patients undergoing in patient treatment at the Bacula Center of the Cardiovascular Surgery in Moscow, without hemodynamically significant pathology of the coronary basin and the left ventricular functional disorders. The most frequently diagnosis was arterial hypertension, as well as peripheral vascular pathology, carotid basin, and Lewy syndrome. Diabetes mellitus, chronic bronchitis, and gastric ulcer were noted risk factors. Among the 26 subjects, 80 men and 8 women. Patients with cardiac arrhythmia and mitral pathology were excluded from the study. According to the obtained echocardiography data, the proportion of the contribution of myocardial segments to the formation of total stroke volume is normally heterogeneous due to difference in the volumes of the segments, which determine the valve stress. However, a strict ratio of the indicators remains. Let's demonstrate it below a table. The end diastolic volume of left ventricular segments varies significantly from 7.7 milliliter in the second segment and to 45.5 milliliter in the fifth segment, and average 114 milliliter. Nevertheless, their left ventricular is not much defined. The minimum in the third segment and the maximum in the first segment, and its average in 67.2%. The average end stroke volume of whales was 37.6 milliliter, with a range from the minimum in segments in the second segment and to the maximum in the fifth segment. The result of the stroke volume are logical. The minimum value is also in the second segment and the maximum in the fifth segment, and the average value is 76.8 milliliter. The uneven in the distribution of the contribution of each segment to the formation of the general contribution function of the left ventricle is confirmed by the following data. The contribution of the fifth segment is 25.7%, fourth segment is 18.42%, first segment is 10.14%, third segment is 3.11%, and the second segment is 5%. Consequently, the end diastolic volume and contractility of each individual segment forms its stroke output, which ultimately determines the overall integral function of the left ventricle as a whole. The obtained data of segmental ejection fraction in the control group of a patient's norm allows us to calculate the volume of each left ventricular segment, which should be relative to the norm, that is percent of the table in the table. That is, given the ejection fraction has a ratio of stroke volume to end diastolic volume in the patient with myocardial infection. By producing the segment equivalently obtained by ejection fraction, which will be normal, and of course it will allow us to determine his proposed stroke volume. In patients with coronary heart diseases under conditions of innate perfusion and increase in the contractility lightly of ischemic myocardial areas is observed with while in necrosis zones. it remained unchanged. Thus, the determination of a variable myocardium as well as assessment of its reserve potential, segmentally and in general. In this category of subjects, it's proposed using a pharmacological test. The determination of the deficit of degree to compensation for segmental function emission is the difference between the actual contribution of the segmental share of pacification in the formation of the total left ventricular ejection fraction and its proposed value in the norm. The calculation is carried out according to the formula when the difference between stroke volume segment is divided into end-diastolic volume segment, and minus stroke volume segment in norm is divided into end-diastolic volume general. So, due to the difference between the actually obtained stroke volume segment and the proposed one, it's possible to assess the blood flow deficit in the segment and therefore in the left ventricle as a whole. In the proposed stroke output normally accepted the real one, the situation is considered as the stroke of the flow. If the situation is opposite, compensatory of the blood flow. This means that it's possible to quantify the prospect of planned myocardial vascularization in the basin of which artery and in what amount it will be justified. To date, a mathematical formula is being created for the methodological and automatic calculation of left ventricular cavity division, according to Hood et al. To reduce the study time, of course, a patient for the invitation of the technique has been developed, which has passed an independent examination of the territory of the Russian Federation and received its official number 2777-235, a method for assessing the contractility of the left ventricular myocardium. The authors of the patient are Nikolai Chigogidze, Leo Bokhary, and Eka Dvalishvili. The patent was developed in honor of the memory of the creator of the methodological and my main teacher, Nikolai Avtandilovich Chigogidze, whom I want to thank for everything. Thank you.
Presents our study, which was the association between psoriasis and atherosclerotic cardiovascular disease, a systematic review and meta-analysis of observational studies. But before I go ahead, I want to be sure everyone can hear me. Am I audible enough?
Yes, doctor, you're audible.
All right, thank you. All right, so this is the outline I'll be going on with. As we all know, psoriasis is a chronic immune-mediated inflammatory disorder of mostly the skin, but it can also affect the skin, the nails, and the joints. It's quite common and has a 2 to 3% global prevalence, and it affects children and adults, but is more common in adults and has. There are different variants of psoriasis. We have the scalp psoriasis, nail psoriasis, inverse psoriasis. I have the whole list here. On the left-hand side of this slide are images of the chronic plaque psoriasis. Let's define cardiovascular disease. They are a group of disorders affecting the heart and blood vessels, and they are one-third of all deaths worldwide. Atherosclerotic cardiovascular disease, ASCVD, is a subgroup of cardiovascular disease, and it refers to all cardiovascular diseases by atherosclerotic disease of blood vessels. And this is classified into coronary artery disease and peripheral artery disease. And these peripheral artery diseases are further classified on the non-coronary side affected. So it could be carotid artery disease, vertebral artery disease, and the list goes on. It's quite important to note that psoriasis, despite it occurs mostly on the skin, studies have shown that it's quite systemic because most times the blood test results shows elevated C-reactive protein. And also studies have also shown that an increased prevalence of CVD risk factors are present in psoriasis patients. And these risk factors include hypertension, diabetes, obesity, metabolic syndrome, and the list goes on. Now, the justification for carrying out this study was there was no systematic review which specifically investigated ASCVD. The aims of this study was to evaluate the association between psoriasis and ASCVD, to evaluate the association between psoriasis and the individual ASCVD types, and also to evaluate ASCVD association according to the severity of psoriasis. These were the databases that we searched, and they include Embase, Scopus, Bayes, and Google Scholar. Our inclusion criteria were we used publications that were published in English language on or before July 2023, observational study designs that were of high quality. We also used publications which evaluated one or more of the clinical types of ASCVD in conjunction with psoriasis. Finally, publications that compared psoriasis patients with controls. And our exclusion criteria were psoriasis group consisting only psoriatic arthritis. We also excluded publications which included participants which were less than 18 years old, participants from only one gender, animal participants. We also excluded publications which had full text, which the full text were unavailable, absence of baseline data, absence of effect measure, and absence of adjustment in the computed effect sizes. These were my colleagues for the study. To analyze our data, we used Comprehensive Meta-Analysis 3.0 and Meta-XL. And the effect measures we used were hazard ratio for the cohort studies and odd ratio for the non-cohort studies. Meta-analyses were based on the random effects model. Heterogeneity was assessed using the Q and I-squared index, and results which had heterogeneity, I-squared index was 0.0% to 25%, moderate was 26% to 50%, high was greater than 50%. For the results, we came out to be high heterogeneity. We went ahead to check for the sensitivity, and we also analyzed the results and presented it using the forest plot. Publication bias was also assessed visually using funnel plots and statistics in Eggers regression tests. This research was completed in partial fulfillment of an MSc program, and it was approved at the University of South Wales, United Kingdom. After we went through the database search, we were able to gather about 28,638 research articles. And by the time we removed duplicates, we came down to 20,879 articles. Then we applied our exclusion criteria, and we were able to arrive at, after we applied the inclusion criteria, we were left with 21 observational studies, which we used for this research. And these 21 observational studies included 3 cross-sectional studies, 1 case control, and 17 cohort studies. And the geographical distribution of these 21 studies were East Asia, Northern Europe. Ascertainment of exposure of psoriasis and ASCVD outcomes in all 21 studies was via reliable sources, which includes medical databases, health insurance databases, national registries, and hospital records. And 14 studies, which is 2/3 of the studies, were classified based on the severity, mild and severe, and included clinical ASCVD outcomes, included ischemic stroke, aortic aneurysm, myocardial infarction, and coronary artery disease. For the quality assessment, we used the Newcastle Ottawa tool for observational studies, and studies with a quality score of greater than or equal to 7 were deemed high quality. As I mentioned earlier, we used the funnel plot for our publication bias, and we achieved an asymmetry suggestive of publication bias. Then we went further to apply, which is a more sensitive way of checking for publication bias, which ruled out publication bias as it came back negative. Here on this slide, we have the forest plots of association between psoriasis and ASCVD. If you can see my cursor, the pooled estimate shows the association between psoriasis and ASCVD, and the heterogeneity is high for the core study and moderate for the non-cohort studies. For the forest plots of association between psoriasis and ischemic stroke, for this study, we only have the cohort study, and the pooled estimate was insignificant from here, and the heterogeneity index, that's the I-squared index, is moderate. Forest plots of association between psoriasis and myocardial infarction shows, it shows a significant association between the two and high heterogeneity for both the cohort and the non-cohort study. Forest plots of association between psoriasis and coronary arteries shows there is a significant association for both studies. However, for the cohort study, the heterogeneity is high. Non-cohort study, the heterogeneity is moderate. Forest plots of association between psoriasis and aortic aneurysm. Again, the pooled estimate is significant. However, the heterogeneity is high. For association between mild psoriasis and ASCVD, the pooled estimate is significant. For the cohort, the heterogeneity is high, and for the non-cohort study, the heterogeneity is low, which was an interesting finding. Association between severe psoriasis and ASCVD, the there was a significant association in both studies. The heterogeneity for the cohort study is high, while that of the non-cohort study is moderate. Now, for the sensitivity analysis, we subjected the studies which had high heterogeneity to sensitivity analysis, and for most of the studies, there was no change in the heterogeneity. However, for the association of severe psoriasis and ASCVD, the heterogeneity dropped from high to moderate. So after we got our results, we came out to discover that we all found that significant positive associations between psoriasis and CVD outcomes, including stroke, myocardial infarction, ischemic heart disease, thromboembolism, arrhythmia, and cardiovascular death. And to explain our findings, what we found basically was that psoriasis and atherosclerosis share the same inflammatory pathway of activation of T helper 1 and T helper 17 cells. And this was further confirmed by a study which also mentioned that when the psoriatic plaques and the atherosclerotic plaques are looked at under the microscope, it shows that they have the same cytokines and cells. The strength of this study is that it was a large-scale study and it had a high statistical power. It also had the highest level of acceptable evidence and high quality of evidence. However, the limitations that were residual confounding, bias in assessment of psoriasis and ASCVD outcomes, high heterogeneity in many of the meta-analyses, as I showed in the forest plot, and also of data for some clinical ASCVD outcomes. The conclusions we drew from this study was that psoriasis, both mild and severe, is associated with increased risk of ASCVD. We also drew that high heterogeneity was observed in our pooled analysis, making us to not be able to draw definite conclusions about the association. Also, residual confounding prevents us from ascertaining that the association between psoriasis and ASCVD is independent. Future observational studies evaluating the association between psoriasis and ASCVD should therefore limit bias and conduct more comprehensive experiments. Implications for our study in medical practice. The implication that psoriasis is common and multiple guidelines on cardiovascular disease primary prevention should recommend the use of chronic immune-mediated inflammatory diseases as risk modifiers. Risk modifiers are factors that can influence an individual's CVD risk beyond traditional risk factors. Primary care physicians may also use psoriasis as a risk modifier that upgrades an individual's CVD risk category, and this will eventually affect the recommended target LDL cholesterol levels and blood pressure for cardiovascular disease prevention. Given the high prevalence of ASCVD risk factors, the management goals for patients with psoriasis should regular ASCVD risk assessments and prompt implementation of preventive measures, which includes lifestyle modification, treatment of ASCVD risk factor conditions, and if indicated, lipid-lowering therapy such as statins, should be commenced. These are my references. Thank you for listening.
Language. As you see, my name is Anastasia with difficult pronunciations surname. I work in Bakulev Center for Cardiovascular Surgery for the Russian Ministry of Health as cardiac surgeon for 7 years. Today, I will tell you about atrial septal defect clinical guidelines, which my colleagues and I made last year. One moment, please. First of all, we will talk about the definition of the disease, and we'll answer on the question, what is it? Then a little bit time we will spend to discussing about etiology and pathogenesis of the ASD. Then we look forward to the epidemiology, and the second part of my presentation contains diagnostic and treatment of this congenital heart disease. Atrial septal defect is a congenital heart disease, and a congenital abnormality of the interior septum that enables blood flow between the left and right atria via the interatrial septum. Secondum atrial septal defect is the most common congenital heart malformation that occurs as an isolated anomaly about 10% of individuals with congenital heart disease. ASD are one of the most common congenital heart defects. According to the Center for Disease Control and Prevention, about 2,000 babies in the United States are born with the ASD every year. This is between 5 and 10% of all children. They're twice as common in women as men, and are the most frequently diagnosed this defect in adults. As you can see, this congenital heart disease is very common all over the world. I think that the lower frequency about this side of planet is different countries is due to a shortage of medical staff and the shortage of the human inability to receive medical care. And now we will talk about etiology and pathogenesis of this disease. As you can see on the picture, we can see here all of genes that are coding this defect. Genetic heterogeneity of atrial septal defect locus has been mapped to chromosome 5p that you can see here. Other forms of atrial septal defect are associated with other congenital heart disease, but no conduction defects or no cardiac abnormalities include ASD2. It's the type of defect, and all of the genes we have here, but nobody knows actually what happens in human that we have this defect. Here we will look forward to the some movie about hemodynamics of this.
In ASD, there is a left to right shunt from the left atrium to the right ventricle. The right atrium gets...
Oh, sorry.
In ASD, there is a left to right shunt from the left atrium to the right ventricle. The right atrium gets enlarged, and so does the right In A
Sorry, something wrong. I will check it. 1 minute, please. Sorry, and once again.
In ASD, there is a left to right shunt from the left atrium to the right ventricle. The right atrium gets enlarged, and so does the right ventricle because of the increased volume. This passes on to the pulmonary artery. Over the years, the pulmonary artery gets enlarged, and there is pulmonary artery hypertension developing. At one point in the course, there is a reversal of the shunt because of the high pressures in the pulmonary artery, leading to a right-to-left shunt from the right atrium to the left atrium, and this deoxygenated blood passes out into the aorta.
And as you can see, hemodynamics determine the pathogenesis of this disease. First of all, we have blood shunt via atria that cause pulmonary over circulation. And then we see right heart. It's contained of both right chambers. We've got right heart volume overload. Because of this, they develop heart rhythm disturbances, high pulmonary hypertension. And all of this, unfortunately, may cause premature death. Non-syndromic ASD is typically clinical occult in control with small transitory ventricle septal defects where the high pressure difference generates a loud noise and even a palpable thrill. There are typically no symptoms and subtle from related things such as fixed wide spleening of the second heart sound or a pulmonary flow murmur. In larger shunt, exercise intolerance, exertion dyspnea, and recurrent pneumonia may occur. Even with good health care, more than 50% do not present until adulthood and the onset of the complications such as atrial fibrillation or pulmonary hypertension and right heart failure. Left ventricle compliance decreases with age, causing increased left to right shunting. By the age of 60 years, almost it will be symptomatic. In the ASD, if the ASD is large, you can hear an abnormal heart murmur when we'll listen to the heart of your patient. After having symptoms, you should go on, and the most common diagnostic test used to confirm an ISD is echocardiogram or ultrasound of the heart. And you can make other tests, but it will be a little bit later, and it will be to assess the impact of ASD on the human. In patients with ASD, the maximum size of the defect is measured in color Doppler mapping mode into directions. The presence, amount, and direction of blood shunting through the internal septum are determined on echo. Left-to-right shunting is usually observed, but it can be bidirectional if high pulmonary hypertension or severe tricuspid insufficiency present in patients. Secondary ISD should be distinguished from patient foramen ovale. In this case, if patient foramen ovale, a flap of the primary septum is visualized next to the defect, and shunting of the blood in the color Doppler mode has an oblique course. On the next picture, we've got a case of a patient with ASD. We've got chest X-ray on the left side, and on X-ray on X-ray of this patient with ASD, we can see normal with when the atrial septal defect is small and there are no complications. But in this occasion, it's a child about 2 years old. We've got enlarged pulmonary vessels through the lung on this area, vessels visible to the peripheral of the lung here. And we've got, as you see, cardiomegaly due to right atrial and right ventricle dilatation. On this video, you can see echo with left to right shunting that because of it we can see the atrial septal defect. The hemodynamic significance of shunt in ASD is assessed using cardiac morphometry, flow diameter, and the ratio of pulmonary to systemic blood. It's the most important ratio that we have. Measuring this ratio is of no use in the presence of high pulmonary vascular resistance on neonates, or if patient has high pulmonary hypertension. Right and left ventricle global longitude is an emerging method for detecting and quantify subtle disturbances in global long axis left ventricle systolic function. And the same thing we will see about left ventricle. And now we know that our patients have ASD. We've got echo, we've got X-ray, and now we should make an operation and make a treatment of this congenital heart disease. And we've got two methods of surgical treatment, and we should decide what kind to choose. In 1953, Dr. John Gibbon successfully closed an ASD using open heart surgery and a heart-lung machine. Since then, ASD have been closed using different materials and approaches until the early 1990s. All ASD were closed with open heart surgery. But now, device closure through a cardiac catheterization has become the first choice to repair secondary ASD if certain criteria are met. About this criteria, we'll talk a little bit later. Surgical closure involves opening the atrium and closing the defect because of suture with a little bit patch. Here we can see indication for the surgery is ratio of pulmonary to systemic blood flow more than 1.5, right ventricle global longitude strain more than this, and left ventricle global longitude more than 60. We should check the index of pulmonary vessels. It should be less than 3 Wood units, because if we've got more than 3 Wood units, it's safe for us that the patient have a pulmonary hypertension. And now we can talk about contradiction for endovascular closure, because we should know how we will operate our patient. And first of all, we've got 2 kinds of contradiction. It's relative or discussable absolute contradiction. First of all, we would talk about relative contradiction. Is low patient weight is less than 15 kilos. Occlusion or congenital interruptions of the inferior vena cava, blood coagulation disorders, peptic ulcer, or other contradiction to the administration of platelet aggregation or inhibitors or anticoagulants. The second part, we should know that patient has pulmonary hypertension with right to left shunting. Minimum distance, we should know on the echo minimum distance from the coronary sinus, and atrioventricular valves or right pulmonary raise should be more than 5 millimeters. And what about absolute contradiction? We cannot make endovascular closure of atrial septal defect if patient has hypoplasia of the left atrium, defect of the sinus venosus, or primary ISD. Because this condition should treat with open heart surgery only. About this, we can say about intracardiac thrombosis or sepsis or combined cardiac anomalies that required surgical correction with open heart surgery too. Here we have post-operative treatment about this patient. It depends on the kind of surgery that we have, but almost all patients, adult patients, have heart failure in post-operative period. It presents in children of the first year, and it's recommended to prescribe diuretics. In patients with concomitant supraventricular arrhythmia in the presence of atrial fissure or fibrillation, of course, antiarrhythmic therapy or interventional treatment of arrhythmia is recommended too, and is recommended for adult patients with ASD to prevent thromboembolic complication if in the presence of atrial fibrillation too. Thank you so much.
And candidate of medicine Kapranova Yulia Sergeyevna. The health of the child population. The health of population, especially children and adolescents, is one of the most social indicators characterizing the level of development of society, social and spiritual well-being of residents of any state. The state of the cardiovascular system. One of the most significant health criteria includes indicators characterizing the functional state and morbidity of the cardiovascular system. This is largely due to the fact that, according to the World Health Organization, diseases of circulatory system traditionally occupy the first rank among the main causes of death in the developed world. This pathology group includes diseases, three of which: coronary heart disease, including myocardial infarction, arterial hypertension, and cerebrovascular disease, including stroke, account for about 80% of deaths. The purpose of the study is to assess the influence of environmental factors on the functioning of cardiovascular system in children and adolescents, followed by the development of preventive measures. The effects of physical exercise on the functioning of the heart. The assessment of the influence of morning gymnastic classes by school children on the functioning of the cardiovascular system was carried out. There are more school children with a heart rate within the age normal of a group of students who were engaged in gymnastics, 39.4%, compared with those who were not engaged in gymnastics, 25.9%, including among boys, 39%, compared with the 23%, and boys with increased heart rate are 1.4 times more among adolescents who didn't do gymnastics when in the group engaged in this exercise. Consequently, gymnastics by school children leads to normalization of their heart rate. Here we see on a slide the proportion of the school children with a different heart rate depending on morning exercises. We see that below the normal range, 20%, and within the normal range is 36%, and above the normal range, 40%. The effect of the lifestyle on the heart symptoms. Using the right statistical methods, the influence of the following factors on the formation of unpleasant sensation from the heart in school children has been established. Active smoking, not observing the daily routine, late bedtime at 11 o'clock or 1 a.m., non-compliance with the diet, insufficient frequency of nutrition, lack of adequate nutrition in an educational institution, refusal from regular consumption of dietary products, unfavorable physiological situation, and drinking tap water with increased risk, salinity, and general hardness. So we see that the effects of the sleep duration on the functioning of the heart. That influence of sleep duration on the functioning of cardiovascular system has been studied, and it found that there were fewer students with normal systolic blood pressure in the general group of the school children and among girls with a sleep duration of 5 till 7 hours per day. That stand for 77.9% and 78.4% compared with the students with a sleep duration of 8 hours, 85%, and 87%. We see on the slide that the proportion of the school children with different values of systolic blood pressure depending on the duration of sleep and percentage. Below the normal range, within the normal range, and above the normal range. The effect of the diet on the functioning of the heart. The assessment of the influence of the diet on the functional state of the cardiovascular system in school children was carried out. There were significantly more students with normal mean arterial pressure in the group of adolescents who followed by diet 85%, compared with the school children who did not follow the specific regime 79%. According to research results, non-compliance with the diet by school children is risk factors for functional disorders in body. The proportion of school children with different values of mean arterial pressure depending on the factor of the diet. Below the normal range, it was 6%, and within the normal range, 85%. The effects of spicy foods on the functioning of the heart. Spicy foods are those with strong concomitant effect, containing fresh pepper, radish, onion, garlic, vinegar, citric acid, and irritating the mucous membranes of the upper digestive tract, stomach. It was found that in the study group of teenage girls who preferred the use of spicy dishes compared with the control group, the prevalence of the chronic disease of the circulatory system is higher, especially among girls. Consequently, the propensity of adolescents to eat spicy dishes is a risk factor for their pathology of the cardiovascular system. The influence of the material and housing level on the functioning of the heart. There are more different studies and students with normal systolic blood pressure in the families with good and the most favorable levels of material and housing level, which has 77% compared with the students in the families with the least favorable and satisfactory material and housing level, 58%. On the contrary, there are more school children with a reduced ADF among insufficiently financially secure students, 38%, than well-off students, 21%. Thus, the low material and housing level of a family is a risk factor for the formation of abnormalities in blood pressure in adolescents. The effect in the industrial emission on the functional reserves of the heart. In the industrial city, the assessment of the levels of the functional reserve of the adolescent heart was performed based on the results of the Ruffier functional test. There are significantly more students with a low and below average levels of functioning reserve of the heart among school children who studied at a distance of 1 kilometer from enterprise, 50%, than among their peers who studied at the distance of from 1 to 3 kilometers, 44%, and more than 3 kilometers from production, 42%. At the same time, school children with above average and high level of functional reserve of the heart, on the contrary, are more numerous in the group of children who studied at a considerable distance from enterprises, more than 3 kilometers, 21%, than before 1 kilometer, 16%, and from 1 till 3 kilometers, 18%. Similar patterns were found in the groups of boys and girls. Consequently, the impact of the body of adolescents of atmospheric pollutant from furnace metallurgy and coal chemistry enterprises in the schools learning areas leads to a decrease in their functional capabilities of the cardiovascular system. The proportion of the adolescents with different level of functional reserve on the heart Ruffier index depending on the distance of the place of study of industrial enterprise. And we see on the slide low and below the average. The average up to 1 kilometer, from 1 to 3 kilometers, and more than 3 kilometers. The effect of atmospheric pollutants on heart disease. It has been established that the incidence of adolescents from 15 till 17 years old with diseases of the circulatory system is determined by average annual content in the atmospheric air of suspended solids, carbon monoxide, phenols, and comprehensive index of atmospheric pollution 7, CIAP7, that is the group of 7 main xenobiotics. A direct, reliable relationship has also been established between the prevalence of disease of the cardiovascular in adolescent and levels of atmospheric pollutants with substances. Consequently, the duration of exposure to atmospheric pollutants on the body of adolescent is sufficient to form a pronounced dependence of morbidity and prevalence of the disease on concentration of xenobiotics in the atmospheric air of the industrial city. We see on the slide correlation coefficient R between the average annual content of harmful substances in the atmospheric area in the incidence of disease. And we could compare the carbon monoxide, suspended solids, dust, phenol, and CIAP7. The effect of drinking water quality on the functioning of the heart. The influence of the water quality of a centralized drinking water supply on the health of the child population has been studied. It was found that a proportion of adolescents with elevated systolic blood pressure was significantly higher in the group of students who constantly or periodically consume raw tap water with increased salinity and general hardness, 6%, compared with the school children who did not use raw tap water, 2%. A similar pattern was also found among boys, respectively 8% compared with 3%. Consequently, the use of water by adolescents with an increased content of dry residue and a high overall hardness is a risk factor for increased blood pressure. Conclusions based on the research results. The first, the systemic practice of morning gymnastics by school children leads to normalization of their heart rate. The second, doing sport related to physical activity in adolescents lead to increase in their functional capabilities of cardiovascular system. The third, unhealthy lifestyle, which includes active smoking, non-observance of the daily routine, late bedtime, irrational nutrition, and psychological situation, raw use water with increased salinity and general hardness, leads to unpleasant sensation from the heart of school children. The fourth, late bedtime and insufficient sleep duration in school children are accompanied by violation of blood pressure parameters in adolescents. Fifth, non-compliance with the diet by school children and the tendency of adolescents to eat spicy dishes is a risk factor for their pathology of the cardiovascular system. 6. The low material and housing level of a family is a risk factor for the formation of abnormalities in blood pressure in adolescents. 7. Exposure of adolescents to atmospheric population from fierce metallurgy and coal chemistry enterprises in the school's learning area leads to an increase in their blood pressure and decrease in functional capabilities of the cardiovascular system. 8. The use of water by adolescents with a high content of dry residue and high overall hardness is a risk factor for increased blood pressure. Recommendations. Proposals have been made for development and implementation of statistical processing system on personal computers of research results in children and adolescents, and includes blood pressure, heart rate, vegetative indices of central hemodynamics, and functional results of the heart rate. Rouffier Index. The data obtained are necessary for the development and implementation of effective measures to improve the functioning of the cardiovascular system and prevent disease of the circulatory system. Advices for the prevention of cardiovascular system. Observance of a healthy lifestyle, smoking cessation, sleep duration, at least 8 hours a day. Going to bed no later than 11 o'clock, and regular physical activity. Second, rational nutrition 3-4 times a day with inclusion of dairy products in the diet and restriction of the use of spicy foods. Drinking clean water with a normal salt content, a favorable psychological situation in society, sufficient material and housing level of a family, comfortable living conditions, and living in ecologically clean areas. Conclusion. Based on the results of the work carried out, the main risk factors of the formation of pathology of the circulatory system and anti-risk factors in the prevention of disease of the system has been identified. Based on the study and assessment of environmental factors affecting the condition and functioning of the circulatory system, a set of effective measures aimed at the prevention of the cardiovascular system in children and adults is proposed. Thanks for your attention and have a wonderful day.
Thank you, Dr. Sergey, for your valuable video presentation. Now we'll have a presentation from Dr. Matthew.
Pathology of low global prevalence on their metastatic origin has been ruled out. 55% of primary cardiac tumors are benign. The most frequent finding being atrial myxoma, followed by lipomas and fibrillatomas. If we analyze the remaining 25%, sarcomas are diagnosed in 3 out of 4 histological analyses. They represent the main malignant primary cardiac tumor. They affect young people with a median age of 39 to 44 years, and the form presentation depends on the size of the mass, its location, and the degree of pulmonary involvement they generate. They can also start with embolics or systemic metastasis. Due to their different forms of presentation, the etiological diagnosis is complex and is usually made retrospective after cardiac surgery. Okay, the presentation of the case is a patient of 50 years old, female, with no relevant medical history, who was hospitalized in another institution for antibiotic treatment in consent of community acquired pneumonia. Since she involved with signs of cardiac signs of her fibrillation, it was released a transthoracic echocardiogram showed a mass in the left atrium adhered to the mitral vein, which generate a stenosis of the left ventricular tract. So she was referred to our institution for student treatment. Can we see here the echo? We can see the mass in the mitral vein that generate in the Doppler important stenosis. She was admitted to the coronary unit with requirement of supplemental oxygen supply by nasal cannula at 2 liters per minute. At the physical examination showed signs of spontaneous heart failure. So she was treated with vasodilators and intravenous diuretics with a poor response. So it was decided to perform emergency surgery. During the surgical procedure, the resection of a whitish indurate fibrous whitish indurate mass fibrous in appearance. It was located in the roof of the left atrium with infiltration of both upper pulmonary and the anterior mitral ligament. She required a mitral valve replacement with mechanical prosthesis with preservation of the posterior subvalvular apparatus and closure of the left atrial roof and interatrial septum with a pericardium patch. The surgery required 127 minutes of cardiopulmonary bypass circulation and 97 minutes of clapping. Here is an image of the mass. It's a mass that almost size 9 centimeters. After the procedure, she was admitted in the cardiovascular recovery room with mechanical ventilation and vascular support. She developed with increased recurrence of vasoactive angels with a response to crystalloid resuscitation. Right catheterization showed signs of vasoplegia. So we did, and transesophageal echocardiogram was performed, which ruled out cardiac tamponade and right chamber involvement. The speed hemodynamic support with high dose of noradrenaline, phenylephrine, and vasopressin. She persists with signs of vasoplegia, so we decided to administer intravenous methylene blue without reversing of this clinical quality of the patient. She progressed with multi-organ dysfunction and died in 12 hours post-operative. 2 weeks later, we obtained the result of the pathological anatomy with a diagnosis of high-risk sarcoma. This is the histological image of the patient. We can see proliferation that's infiltrate with a high infiltration of myocardial with cellular pleomorphism. So, what is the conclusion of the case? We interpret that the refractory vasoplay shot observed in this case will be explained by the combination of basal pro-inflammatory states, secondary to and neoplants associated with inherent nausea to extracorporeal circulation. It must be taken into account to the behavior of the sarcoma significantly affects post-operative mortality. Therefore, a correct diagnosis pertinent to guide the therapy. In echocardiographic diagnosis, sarcoma can morphological mimic a myxoma, and its diagnostic pre-surgical difference is complex. According to the bibliography published on the subject, the degree of myocardial infiltration and the metabolic activity of that tissue can be evaluated previously by a cardiac magnetic resonance and with a PET-CT. The elective framing of the sarcoma consists, it is possible, in a complete surgical resuscitation, chemotherapy, and radiotherapy. In conclusion, we highlight that when the situation of the patient clinic allows, it should be complemented with an MRI cardiac or a PET-CT to predict the degree of infiltration myocardial and guide the surgical strategy. It stands to reason to think that in very advanced scans where a very strong image identify a significant infiltration myocardial, palliative behavior may be chosen, avoid surgeries with an acceptable morbidity and mortality, and if not, select the appropriate route approach and the surgical technique used before entering the operation room, with the aim of reducing the extracorporeal circulation signs and therefore the post-operatory vasoplay shock. Okay, thank you.
Thank you, Dr. Matthew, for your valuable presentation. If attendees have any queries, they can unmute yourself and come up with your queries.
Thank you for the invitation.
The senses, taste, smell, sight, hearing, and proprioceptions contribute the identification of foods and determine their reward levels or hedonic characteristics. For this reason, the response of the sensory receptors influence both the stimulation and the inhibition of food intake. Taste, in particular, is a complex senses that detect a wide range of chemical molecules but translate them in a limited number of distinct perception called flavors, such as sour, salty, sweet, bitter, and umami. This perception influences the acceptability of food and play a crucial role in the human survival. Furthermore, their impact extends to overall health. However, some studies suggest that the difference in taste perception have a neuronal origin and are influenced by factors such as sex, age, ethnicity, and others. There are key to guidance future research on the pathophysiology of taste perception in humans. Likewise, it is well accepted that all medical conditions associated with the pathophysiologies require a dietary adjustment. However, a little has been studied in depth regarding the relationship between the physiological, anatomical, and sensory changes inherent to disease, and how this influences food choice of after dietary patterns. In parallel, excess body fat or excess in adiposity reflects in terms of overweight or obesity has become a medical condition of almost importance as a risk factor of the development of many chronic non-communicable diseases. And the waist to hip ratio has been strongly established as a predictor of cardiovascular risk. Since increased abdominal adiposity tissue can impair lipid and glucose metabolism, which increase cardiovascular risk. In addition, other studies suggest difference in certain aspects of taste. For example, satiety of sweetness may occur more slowly in obese people compared to normal weight, possibility stimulation greater intake. Therefore, the present work aims to evaluate whether excess adiposity is correlated with the alteration in chemioperception of basic taste: sweet, salty, sour, umami, bitter, and astringent, and in the global perceived by young adults, in addition to evaluating the difference in men and women. Regarding materials and methods, the study was quantitative. Descriptive cross-sectional study was conducted on 14 women and 8 men, randomly selected and regularly enrolled during the months of February to December 2018. The sample size calculation was done considering a population of the 1,500 students of the biochemical engineer degree at the National Technological Institute of Mexico in Guanajuato, Mexico. The exclusion criteria were being a smoker, consumption alcohol beverage, having excess coffee consumption more than 3 times a week, and or presenting any chronic non-communicable disease. During the study, the ethical principles of dignity, protection of rights, and well-being of participants were respected, following the regulation on the General Health Law on Health Research and the Declaration of Helsinki. Participants received training with basic tests on 10-point intensity scales. The calibration stand used for the test were sucrose, were the sweet taste, caffeine for the bitter taste, citric acid for the sour taste, sodium monochloride for the salty taste, monosodium glutamate for the umami taste, and quinone hydrochloride for the astringent sensation. The training was carried out during the 25 sessions per month, distributed in 5 sessions per week, each lasting 1 hour. and having a daily frequency except for the weekend. Anthropometric measures were performed by a nutritional specialist using a brown fiberglass tape, one brown stadimeter, and a digital scale. The anthropometric indices used to diagnostic excess of body fat and cardiovascular risk was the waist hip ratio, which considered the cut-off point for the Hispanic population for men less 0.80 and women less than 0.85. For statistical analysis, the collect data were expressed as the mean plus standard deviation. Data normality was verified using the Shapiro-Wilk test to analyze the subject's general parameters as student test for independent samples was applied, and to evaluate the association between taste and anthropometric indices. A simple correspondence was analysis performed. Finally, the results were corroborated by a Pearson correlation using ABM SPSS software version 26. For the results, in this figure, students were identified and categorized as showing difference in adiposity according to the waist-hip ratio. The results indicate that 78.6% of women had adequate adiposity with an average of 0.48. In the case of men, 50% had inadequate adiposity, an average of 0.72 considering the waist-hip ratio. It is known that the people might experience alteration in the taste perception or chronic dysgeusia because of true stimulants in the mouth, for example, the taste of an oral infection, or when stimulated research taste receptor through the bloodstream, for example, the persistent bitterness or some medication. Considering the visceral adiposity represents a risk factor that can alter the composition of the blood profile in more than half of the subjects evaluated, and in addition, other authors suggest have indicated that the obesity modifies the blood profile, especially in terms of lipids, monosaccharides, and ferritin, which could become a cause of dysgeusia. Consequently, it is quite possible that excessive adiposity causes dysgeusia, assumption that will be corroborated as the discussion progresses. In order to verify the presence of body difference between the groups, this table presents the descriptive characteristic of the subjects by waist-to-hip ratio core point. It was observed that 64% of the study population were women, with an average weight of 64 kilograms and height 1.6 meters. In the case of men, the average weight was 78 kilograms and 81.7 meters. Likewise, the average values for the waist circumference in women and men exceeded 80 centimeters and 40 centimeters, respectively. Furthermore, it was observed that the regulations of sex and aspect, all anthropometric parameters show a significant difference between subjects with inadequate adiposity and adequate adiposity. Regarding the body distribution, the anthropometric difference inherent to the anatomical characteristics of each sex were confirmed. The gluteal femoral adiposity of women are larger than the those of men, while the abdominal adiposity are comparable between both sexes, and the visceral adiposity in women are smaller. The high values in the waist circumference of the participants as agreed with the reported of Mexican population, whose theoretical parameters are 87 centimeters for women and 100 centimeters for men. Although these results are alarming, they unfortunately are aligned with the prevalence of overweight and obesity reported by the National Institute of Public Health during the years of 2018 and 2018 for Mexico, where 54% of young adults are overweight or obese, regardless of gender. Since the present study was not designed to assess possible mechanisms, the reason for this difference in detection and explanation threshold for the taste presences are unknown. However, some speculative hypotheses are proposed to be learned regarding the results obtained based on current information in the literature. This figure presents the multiple correspondence analysis for the flavor component and white heap radio. For dimension 1, Cronbach alpha value of 0.92 was obtained, and a G value of 90.43 and inertia of 0.26. The main association variables in this dimension are salty, sweet, astringency, and overall perception in the relation to sex. For dimension 1, salty was found to be correlated with the variable sex, which is consistent with the reports in the literature, and indicate possible gender difference in optimal levels of salt concentration perception. However, data are contradictory as together men or women prefer higher levels of salt. Also, sweet taste has greater importance for this dimension, but showed a low relationship with the other tastes, which was partly expected since the literature is inconclusive the association between obesity and reduced sweet taste perception. Regarding dimension 2, the Cronbach alpha value was 0.91 and a value of 8.85, an inertia of 0.24. In this dimension, it was observed that white heap radio showed a remarkable correspondence with the bitter, sour, and umami taste variables. The component 2 suggests that the taste association with regulation food intake, bitter and astringent, have a significant association with the white heap radio. One possible explanation is that these tastes seem the same to warn to the body of potential danger as a count-to-go slow signal. In the other words, the analysis suggests that the bitter taste may not function as an indicator of high palatability relative to the adiposity. This phenomenon has been termed taste consequence learning and suggests that the all-talk bitter taste in a netly implantation. This aspect has evolutionary significance as it is present in multiple species. However, innate aversion to bitterness can also be overcome through the learning process involving rewards. On the other hand, astringent is considered a negative quality of taste, since its elevated presence increases the probability of food rejection. Overall, the statistical results suggest that this flavor, bitter and sourness, in a physiological way, will be helping to regulation intake to maintain adequate levels of adiposity. It is also worth mentioning that the umami taste present in this component is associated by other authors as a target of dietary therapy. It has been observed that women with obesity have a lower taste sensitivity to monosodium glutamate and prefer high concentration compared to of women or normal weight. In the same test, they are grouping the data according to cardiovascular risk and the intensity in the perception of the flavor. The distribution of the quadrant as was followed. In quadrant 4, the variables white heap radio, adequate inadequate adiposity are grouped with the male sex, together with the perception of the astringent, bitter, and global flavors in the excellent category, as well as the umami and sweet flavors at a good perception level. In quadrant 2, the sweet flavor at a poor umami, good sweet, and astringent perception level relates to white heap radio, adequate adiposity with the female sex, and excellent perception of the sour and umami flavor, as well as good perception of the bitter flavor. This table shows the correlation between cardiovascular risk and taste perception. In men, only the inadequate adiposity group show a significant negative correlation between bitter and taste and white heap radio. This can be explained considering that the obese subject usually have a higher levels of ferritin compared to people with normal weight, because ferritin is not only a marker of iron stores in the body, but also an to a facet rectum, which means that its level can increase in response to inflammation, especially when there is accumulation of visceral adiposity tissue. In addition, excess adiposity tissue also contribute to insulin resistance and increased release of inflammatory cytokines, which is related to increased ferritin. Hence, the results suggest that the men with inadequate adiposity have a reduced ability to perceive bitter taste due to the high concentration of ferritin and required higher external concentration to detect it. For the woman with inadequate adiposity, overall taste showed a positive correlation with the waist hip radius and significant correlation with the sweet, salt, umami, and astringent taste. In the case of the sweet taste, one study suggests that the people with obesity rate higher concentration of sweet taste as more pleasant. And in marine models with obesity with the perception of the sweet taste is influenced by peripheral factors such as leptin and glucagon-like peptide 1, suggesting that the signal produced by adiposities might be fundamental to generate a reward response to monosaccharides. For the umami taste perception, literature has been reported that obese women have been observed to have a significantly higher monosodium glutamate detection in threshold, preferring high concentration to normal weight women, and although the mechanism is not clear, it's believed that it depends on the secondary activation of sweet taste receptor. Finally, the astringency. It is known that the level of intensity is which is astringent is perceived varies between individuals and can influence the acceptation of food rich in polyphenols, mainly foods of plant origin, suggesting that this fact could affect eating habits, promoting a lower consumption of food rich in polyphenols. In addition to the above, it was observed that the taste function between sexes showed greater sensitivity in women compared to men, which is consistent with some previous studies. In conclusion, the result of this study supports the hypothesis that the obese and not obese differ in the taste perception. However, longitudinal studies are required to confirm these cross-sectional results. The gustatory system seems to be much more susceptible than original thought by endocrine and paracrine process. However, to data, this modulation are only marginally understood. Therefore, future studies on the taste sensibility and hormonal status in obese subject are required. Eventually, this could help development future strategies at obesity prevention, therapies, and nutritional education could already focus on taste preference. This is some reference, and thank you very much for your attention.
Thank you, Dr. Dulce Maria, for your valuable presentation. If attendees have any queries, they can unmute yourself and come up with your queries.
After surgical treatment of the primary mitral disease. However, medical management of severe tricuspid disease was associated with one-year mortality rates of 42% and 36%. Even mild TR was associated with a nearly 30% increase in all-cause long-term mortality. And operative mortality from isolated tricuspid valve surgery has ranged from 8 to 10%. So transcatheter tricuspid valve interventions are becoming increasingly widespread. First, I'm going to talk about tricuspid transcatheter edge-to-edge repair. Tricuspid TR began with the TriLuminate early feasibility study using the TriClip system in the United States and Europe in 2017. In the US, TriLuminate pivotal study started in 2019. TriClip G4, like MitraClip G4, has 4 different types, NT, NTW, XT, and XTW, according to the length and width. The delivery system is a 24 French transfemoral system. One-year outcomes of the TriLuminate pivotal study was published last year in the New England Journal of Medicine. The inclusion criteria were symptomatic severe or greater TR, NYH class 2 or higher, pulmonary artery systolic pressure below 70, and patients who had received GDMT for more than 30 days. Of the 172 patients in the TR group, the implant success rate was 99%. The mean number of clips per patient was 2.2. The mean procedure time was 90 minutes. The median length of hospital stay was 1 day, and there was one case of 30-day mortality, which was not related to the procedure. Regarding QOL outcomes, baseline NYHA in the TR group was 53% class 3 and 45% class 2, which improved to 60% class 3, 51% class 2, and 32% class 1 after 1 year. Additionally, the KCCQ score increased by an average of 12.3 points in the TR group, significantly improved compared to the control group's 0.6 point increase. There was no significant difference in all-cause mortality or the need for tricuspid valve surgery within 1 year between the two groups, which is 16 patients in TR group and 18 patients in control group. Similarly, the rate of hospitalization due to heart failure within 1 year showed no significant difference, with 0.21 events per patient year in TR group and 0.17 in control group. Echocardiographic outcomes showed that while 97% of patients in TR group had severe or greater TR at baseline, this reduced to 11% after 1 year, with 51% mild TR and 38% moderate TR. Regarding adverse events, tricuspid surgery was needed in 3 cases in both TR and control groups, pacemaker or ICD implantation in 5 cases in both groups, major bleeding in 12 cases in TR group. There was no device embolization or thrombosis in TR group. Thus, the TriLuminate 1-year outcomes indicated improvements in QOL measures such as NYHA and KCCQ scores and echocardiographic findings. Based on these results, the TriClip system was FDA approved in April this year. Next is a CLASP TR study using the Pascal system. Early feasibility study and pivotal study started in the United States in 2019. The Pascal system, like the mitral version, comes in 2 types: Pascal, commonly known as P10, and ACE. The P10 is 16 mm in length and 10 mm in width, while the ACE is 15 mm in length and 6 mm in width. One notable feature of the Pascal system is that it can be elongated to nearly a straight line, making it less likely to stuck in cord. The delivery system is a 22 French transfemoral system. 1-year outcomes of the CLASP TR early feasibility study was published in JACC last year. The implant success rate was 90%, with 46% using 1 device and 41% using 2 devices. The causes of unsuccessful implants in 6 cases were severe tethering, complex cord structure, and large papillary muscle. Major adverse events included cardiovascular mortality in 5 cases, stroke in 3 cases, severe bleeding in 6 cases, vascular complications in 2 cases, and heart failure hospitalization in 12 cases. Single leaflet device attachment occurred in 3 cases within 30 days post-procedure, with 1 case requiring surgical removal and tricuspid valve repair. 1-year survival rate was 87%. 78% of patients did not require hospitalization for heart failure. At 30 days, 70% of patients had moderate or less TR, and 86% after 1 year, which significantly decreased from baseline. Regarding right heart remodeling, echocardiographic findings showed significant reduction in tricuspid annulus diameter, RV end diastolic diameter, TR jet area, RA volume, and IVC diameter after 1 year. QOL improvements were significant, with 92% of patients achieving NYHA class 2 or less, and significant improvements in KCCQ score and 6 minutes walk distance after 1 year. Next is TTVR, transcatheter tricuspid valve replacement. TRISCEND early feasibility study using EVOKE system and Intrepid early feasibility study started in 2020, and the TRISCEND 2 pivotal study started in 2021. EVOKE is a self-expanding valve with a nitinol frame, bovine pericardial leaflets, and an intra-annular sealing skirt, featuring 9 anchors around the valve to capture the native leaflet and anchor the valve to the native annulus. It comes in 4 sizes, 44, 48, 52, and with a recently added 56 mm size. The inner valve size is 28 mm for all, and the delivery system is a 28 French transfemoral system. 30-day outcomes of the TRISCEND early feasibility study was published in JACC Intervention last year. The inclusion criteria were symptomatic moderate or greater TR, either primary or secondary TR. 6 months anticoagulation was recommended post-procedure. 56 patients were enrolled, with a device success rate of 98%, and the mean implantation time from device insertion to release was 70 minutes. Major adverse events included cardiovascular mortality in 1 case, tricuspid valve intervention in 2 cases, and severe bleeding in 15 cases. Echocardiographic findings showed 98% of patients had TR mild or less at 30 days post-procedure. QOL outcomes showed significant improvements, with 78% of patients achieving NYHA class 2 or less after 30 days, along with significant improvements in 6-minute walk distance and KCCQ score. Based on these results, EVOKE system was FDA approved in February this year. Intrepid system also features self-expanding bovine pericardial leaflets available in 2 sizes, 42 mm and 48 mm, with inner valve size of 27 mm. The anchoring mechanism differs from EVOKE, using an atrial brim that fits around the annulus on the atrial side without capturing the leaflets. The delivery system is a 35 French transfemoral system. Due to the large delivery system, initial procedures recommended surgical cut down of the groin. But as vascular complications were common, we are now performing percutaneously. The early feasibility study is ongoing. Next is our institution's TTVI experience. Since performing the first case of the TRILUMINATE pivotal study in September 2020, we have conducted 29 tricuspid TR cases. These include 22 TriClip cases, 7 clinical trials, and 13 off-label uses, with 7 of off-label use performed simultaneously with mitral clip, and 2 commercial use. And we performed 5 Pascal clasp 2 TR study cases. Mean patient age was 78 years. 90 patients were female. 21 patients were in NYHA class 3 and 8 were in class 2. The pathology of TR was atrial secondary in 26 cases, mixed in 1, and pacemaker related in 1. 22 patients had atrial fibrillation. 2 patients had a history of pacemaker or ICD implantation. Previous cardiac surgeries included aortic valve surgery in 4 patients and mitral clip in 2 cases. 25 patients were EF more than 50%. TR grade was moderate in 3 patients, severe 21, massive 3, and torrential in 2 patients. The number of implanted clips was 1 in 3 cases, 2 in 24 cases, and 3 in 2 cases. The clipping location typically involves placing one clip as the anteroseptal and another as the posteroseptal to create a triple orifice. Since the approval of XTW device, we have used the XTW in all cases, and for Pascal, we use the ACE exclusively. The main reason for using ACE is that its narrower width compared to Pascal P10 makes it less likely to get stuck in cord. This is 30-day outcomes of 17 tricuspid TR cases, excluding the cases performed concomitant with mitral clip. Baseline TR was moderate in 2 cases, severe in 13 cases, massive in 1, and torrential in 1. At 30 days post-procedure, TR was mild in 9 cases, moderate in 3, and severe in 5. Among the 12 patients from the clinical studies, baseline NYHA was class 2 in 4 cases and class 3 in 8. At 30 days post-procedure, it improved to class 1 in 2 cases and class 2 in 4 and class 3 in 6. This is 1-year outcomes of the 9 patients who have been followed up for more than 1 year post-procedure. TR severity remained the same as at 30 days, with 4 mild, 3 moderate, and 2 severe after 1 year. NYHA was class 2 in 7 cases and class 3 in 2. Next is TTVR. We have performed total 28 TTVR, 90 cases using EVOQUE system, including 16 clinical studies and 3 commercial use. We have performed 5 intermediate early feasibility studies. We performed 4 compassionate use cases of LUX valve in 2 cases, cardio valve in 1, and tric valve in 1. Mean age was 68 years old, all females. 14 patients were in NYHA class 3 and 10 patients were in class 2. Pathology of TR was atrial secondary in 21 patients and mixed in 3 patients. 16 patients had atrial fibrillation. 5 patients had a history of pacemaker or ICD implantation. Previous cardiac surgeries included aortic valve related in 4 cases and mitral valve related in 7. 23 patients had EF more than 50%. TR grade was severe in 20 patients, massive in 2, and torrential in 2 patients. This is 30-day outcomes of the clinical study patients. The baseline TR was severe in 13 cases, massive in 2, and torrential in 1. At 30 days post-procedure, TR was none in 1 case, trace in 10, and mild in 5. 4 cases had a mean pressure gradient above 5 post-procedure. Baseline NYHA was class 2 in 5 cases and class 3 in 11. Improved to class 1 in 1 case, class 2 in 7, and class 3 in 8 at 30 days post-procedure. Lastly, regarding the devices used under compassionate use at our institution, LUX valve features a right internal jugular vein approach, and its anchoring mechanism involves an interventricular anchor fixing the device to the interventricular septum. not relying on radial force. Trick valve is characterized by heterotopic implantation, placing devices in both the SBC and IBC. It is suitable for cases where orthotopic implantation is anatomically or hemodynamically unfeasible. Besides these devices, various other devices are under development, and future clinical trials are awaited. Thank you.
Thank you, Dr. Tadashiha, for your valuable presentation. If attendees have any queries, they can unmute yourself and come up with your queries.
And management of post-op vasoplegia, post-cardiopulmonary bypass vasoplegia, and blood pressure management in the ICU is one of my pet projects. So I'm here to talk about that. So I'll go ahead and start. My topic is going to be blood pressure goals in the cardiac critical care unit, especially just because these patients are not your typical critical care patients where all we have to monitor is the blood pressure, and these patients typically require more advanced monitoring and not one particular number that we look at. Okay. So this is just a brief content. We're going to talk about why I'm giving this topic, what is an appropriate blood pressure target in the cardiac ICU, identifying different patient populations and personalizing their blood pressure targets, whether we should be choosing MAP versus other indicators of tissue perfusion and patient management, certain basic and advanced monitoring and diagnostic modalities to monitor blood pressure in the ICU, and using intraoperative data to guide your post-op blood pressure management in the ICU. Okay, we'll move on to the next slide. So as we spoke, blood pressure is a common measurement, right, in most of our patients. Any patient that we come, it's one of your vital signs that you take, include in temperature, heart rate, blood pressure, and everything. So what is the target blood pressure that we use? Historically, people have come up with this one number, a MAP of 65, or we have, a traditional systolic over diastolic blood pressure of 120 over 80. And that is okay for any normal patient. It's just an arbitrary number and with a baseline of 20 above or below that. But in our world, in the cardiac ICU, especially in the cardiac critical care, our patients are more complicated. They're on mechanical support, they're on other drugs, and they have valvular pathologies. So in these kind of patients, we can just stick to one arbitrary number that we monitor, and we have to look at the whole patient picture as a whole, which is why this topic is important and why it's close to my heart and why we're talking about this today. So most of these patients in our critical care units are not in the physiological baseline. Our goal is to get them towards the physiological baseline, but what is a baseline for you and me may not be a baseline for these patients. And what is important is to diagnose hypoperfusion versus hypotension in these patients, particularly in the cardiac intensive care, because it's the hypoperfusion is actually linked more to poor outcomes and increased mortality versus isolated hypotension itself, which hypotension can be an arbitrary diagnosis in any of these patients because they don't usually fall under the physiological baseline. So the consensus guidelines recently state that cardiogenic shock is now defined by hypoperfusion and hypotension, which leads to worse outcomes in these patients. I'll go to the next slide. So there are certain landmark studies which have studied that. I've only included 3 studies over here, but this arbitrary number, the MAP of 65, has been studied extensively. There are various studies. And as you can imagine, it's kind of hard to randomize patients to either a lower or a higher target group. A higher target group is fine a little bit, right? Because more blood pressure, the better is our mentality. But it's hard to randomize somebody to a lower blood pressure group. So none of these studies will have ever targeted a MAP less than 65, and their target group has been the MAP of 65 is a lower target group, whereas a MAP of 75 of 80 has been the higher target group. So these studies have shown that every unit of time spent at a MAP less than 65 has been strongly associated with increased risk of myocardial infarction, acute kidney injury, and increased mortality in the ICU. And patients with cardiogenic shock, particularly with a 24-hour average MAP of less than 65, have been shown to have a mortality rate exceeding 70%. When it comes to stroke, a sustained MAP less than 64, both during and after cardiopulmonary bypass, is strongly associated with acute perioperative stroke, which is why we have come up with this magic number of 65. But are there certain patient populations where we should be targeting a higher MAP than this, or certain patient populations where we should just allow for permissive hypotension to allow for better cardiac output? So that's the goal of this lecture and what we are hoping to talk about here and discuss further on the important monitoring modalities. We'll go to the next slide, please. So the blood pressure targets, like I spoke about, is to appropriately identify the targets in the ICU, considering special patient populations and outlining the risk factors and predictors of end organ failure. Because our ultimate end goal for all of this is to predict and prevent end organ failure. Mostly the kidneys, obviously, because they take the first hit, but also protecting the brain. Because if you're just targeting a particular number, then all we're looking at is numbers and we're not treating the patient as a whole, and we can end up with devastating complications from it. Next slide, please. So what is an appropriate blood pressure target in the cardiac ICU? I'll give you all a minute to think about for the people who practice cardiac anesthesia here or cardiac critical care or work in the critical care ICU taking care of cardiac patients. When you round on your patients every day or you're taking care of patients, what is a blood pressure target that I'll give you a minute to think about that comes up to your mind what you're going to use? And I'm sure it varies between all of us, but universally, I hope across different countries across the world, also MAP of 65 is an arbitrary number. And I'll leave some time in the discussion afterwards to discuss if you all have other thoughts. We'll go on to the next slide, please. So like I said, historical perspective, historically MAP less than 65 for more than 2 hours has been associated with increased mortality, especially in patients with sepsis or distributive shock. And this has at least been extensively studied in various landmark studies to show that a MAP of less than 65 has definitively shown to increase the mortality in this subset of patients. Next slide, please. So if not a MAP of 65, what are the other blood pressure targets that we should be using? So a study which compared a MAP of 80 to 85 with current recommendations actually found no difference in mortality, but it did find a decreased need for renal replacement therapy in patients with chronic hypertension. In the critically ill cardiac patient population, the diastolic blood pressure could be an important determinant of coronary blood flow, and a diastolic blood pressure of less than 60 has been associated with increased risk of myocardial injury. In the sepsis-SAM trial, patients with chronic hypertension had significantly more renal injury if exposed to a MAP of 70 to 75, which was actually the lower target group in that study. Because if you look at it, and we're all targeting a MAP of 65, then a MAP of 70 to 75 should be in the higher range. But in the sepsis-SAM trial, they randomized patients to a lower target group of MAP of 70 to 75, and the higher target group was a MAP of 80 to 85. And ironically, they did find the patients with a higher MAP target group, even though they had decreased need for renal replacement therapy, did have more incidence of arrhythmias, possibly because of use of inotropes and vasopressors with inotropy action to increase the MAP, which could have contributed to the arrhythmias. Nevertheless, they were at increased risk of arrhythmias. But all of this shows that patients with chronic kidney disease going on cardiopulmonary bypass or patients with chronic hypertension whose cerebral autoregulation has shifted to the right will need a higher blood pressure target than we traditionally follow to prevent a stroke and renal injury perioperatively. Next slide, please. So how do we go about personalizing targets then? If one size doesn't fit all, if a map of 65 is not your target for every patient, then how do you select which patient needs a lower mark target versus a higher mark target? So for this, obviously, that's why we're specialized in this field, and we need to individualize based on the patient's comorbidities, understanding their operative interventions, and understanding the presence of mechanical circulatory support, and how these devices work, and how to optimize flow and perfusion to the end organs. Next slide, please. So I'm going to talk a little bit more about identifying different patient populations, the most common ones that we encounter in our everyday day-to-day life in the cardiac OR, and how to personalize blood pressure targets for these patients. Next slide, please. So first we'll talk about patients requiring higher MAP goals. I already touched upon this a little bit earlier, that patients with chronic hypertension who live at a higher blood pressure and a higher MAP goal per se will need a higher MAP goal either on cardiopulmonary bypass or post-op in the ICU because the cerebral autoregulation has shifted to the right. And also patients with chronic kidney disease, when they go on cardiopulmonary bypass, are at risk for AKI on top of the kidney disease. And so these patients tend to require less renal replacement therapy if they also are targeted at a higher MAP goal intraoperatively. Having said that, most often the patients with RV failure, particularly post-heart transplant with RV dysfunction, and those with longer cardiopulmonary bypass times may need higher MAP goals to optimize tissue perfusion. And the ways to do this, I'll talk about this in monitoring monitoring modalities and diagnostic modalities that we use later. But obviously, in all of these patients with heart transplants or predicting RV failure, which is not a normal EF cardiopulmonary bypass case, will 100% get echocardiography intraoperatively. And we can use that as a guide to monitor our MAP goals. And also, if patients are on a longer CPB time, we can also monitor the urine output and adjust your MAP goals accordingly to optimize urine output for these patients. Echocardiographic evidence has shown that an RV function automatically does get better when you target a higher systolic blood pressure in these patients. And in heart transplant patients, the RV dysfunction does tend to get better with a higher systolic blood pressure of 140 and a MAP close to 80. Although there are no landmark studies for these patients because it's a very difficult patient population and it's hard to come up with numbers, especially when you're trying to bring about a one-size-fits-all. So I would suggest that for these kind of patient populations with multiple things going on and multiple comorbidities, it has to be adjusted on a case-to-case basis. And our ultimate end goal has to be end organ perfusion. And we'll talk later about how we're monitoring end organ perfusion and optimizing flow versus perfusion in these patients. Next slide, please. Then we'll talk about some patients who may actually require lower MAP goals. And initially, before the patients go on cardiopulmonary bypass support or on mechanical support devices, when patients have severe LV dysfunction, you kind of have to achieve a balance between the flow and the perfusion. If you give a high afterload to these patients, thinking that a higher MAP is better, in general, then the patient's LV dysfunction may actually get worse because the LV has to pump against all of this afterload. Similarly, patients with post-aortic surgery, especially in the critical care unit, will require lower MAP goals, not per se to optimize perfusion, but because these patients are at extremely high risk for bleeding post-operatively, and you do not want to target a higher MAP than necessary for these patients because the aorta is a high-pressure system, and which has been recently grafted. And if you increase the pressure in this already high pressure system more than necessary, then you end up with bleeding complications and then the vicious cycle of bleeding and coagulopathy, which is not optimal. So as critical care intensivists and physicians who take care of these complex patients, we have to optimize everything to achieve that fine balance between flow and perfusion in these patients. Moving on to the next slide, please. So how do we choose MAP versus indicators of tissue perfusion? Like I said, for me, at least, MAP is just an arbitrary number. I tend to look at the patient as a whole, and I target tissue perfusion. So I'll move on to the next slide. And how do we do that? So cardiogenic shock is a continuum which including isolated hypotension with preserved organ perfusion and isolated organ hypoperfusion despite preserved blood pressure. So your blood pressure can be low, your blood pressure can be high. In these patients, at least, it doesn't matter if they're going on for hypoperfusion and end organ hypoperfusion, and ultimately leads to end organ failure. So for me personally, lactate is a great indicator of tissue hypoperfusion, and that's the first thing that I do in almost all of the institutes. It's easily available lab value, and a rising lactate, or at least getting a baseline initially, and a rising lactate is an indicator of poor tissue perfusion, and that should indicate us as to whether this particular patient needs their flow optimized versus their blood pressure. For example, if the patient has an aortic regurgitation or mitral regurgitation, in these kind of patients, the more blood pressure you target, you're going to worsen their regurgitant lesion, leading to more AI and more MR and literally no forward flow. So you will notice in these patients, although they may have a normal or a higher blood pressure, their end organ perfusion is getting worse, their lactate is getting worse. That's because there is no forward flow. In these patients, then you may have to play a little bit with decreasing your blood pressure to see if you can increase the forward flow before surgical repair of these valves can be taken. And also with these patients, immediately rushing to the cardiac operating room is not an option because of availability or various other comorbidities. Then advanced monitoring modalities like an intraoperative, like an transesophageal TEE, echocardiography, or placement of a PA catheter to monitor your cardiac output, and cardiac indices is very important. An ideal cardiac index is 2.2, at least for optimizing your end organ perfusion. And more than that, I think the mixed venous saturation is a better indicator of how well the patient is perfusing their distal capillaries and their end organs, and monitoring the trend of that, and trying to achieve those numbers to a baseline by optimizing oxygenation, optimizing your hemoglobin, and your flow overall should all be a target in these patients instead of targeting the blood pressure alone. Next slide, please. So we spoke a little bit about this, optimizing the flow versus pressure targets, and how do we target a specific flow rate? This especially kind of applies to mechanical support, patients who are on mechanical support. And the mechanical supports that we most commonly encounter are a balloon pump, impeller, left ventricular assist device as a destination therapy, and ECMO. A balloon pump itself doesn't really do anything or give you any flow rates. It just augments the cardiac output. In my years of practice, that I've noticed that it augments your ejection fraction by 10 to 15% on an average. And so that's what I aim towards, but you can't really target a flow rate on your balloon pump. When it comes to an impeller, that is the left-sided impeller, you can get a flow rate up to 8 liters on your impeller 5.5. But our ideal average cardiac output should be around 4 to 5 liters. And how do we optimize the flow rate in these patients? Again, by using your lab markers. The common ones that I use are lactate and a mixed venous, a continuous mixed venous from your PA catheter, or by drawing a PaO2 lab sample and monitoring via that. If you have either transthoracic echocardiography or transesophageal echocardiography, they're again great ways to monitor the cardiac output, mostly by seeing if the heart is decompressed enough, if your interventricular septum is midline, which kind of tells you that the right-sided and left-sided circulation are in balance and your cardiac output is adequate to perfuse the rest of the body. And same goes with LVADs and ECMO. For any average-sized patient, the flow is anywhere between 4 to 5 liters. Some patients may need higher flow, some patients may need lower flows, depending on what their intrinsic cardiac function is. But all of these devices, again, per se, the impeller and the LVAD, which is used as a destination therapy, is extremely sensitive to afterload. And If you just set these patients at a particular RPM and you are not monitoring their pressure requirements or what their actual afterload is, if their pain is not optimized, sedation is not optimized, if these patients were to have an increase in afterload for any reason, then these devices are extremely flow sensitive and their flow will decrease. So even though you have a normal or above normal blood pressure, then your cardiac output is affected. And again, which leads to poor end organ perfusion. Next slide, please. So we spoke a little bit about all the other clinical markers earlier, which is lactate, mixed venous, and your PA pressures. And if you have echocardiography, it is the best modality per se to monitor your heart itself and to make sure your valvular lesions are appropriately decompressed, your LV is decompressed. And of course, urine output is a big marker clinically in these patients. If you have decreasing urine output, it means that you're not perfusing your kidneys enough. And that's the first one that almost always gives us a clinical clue that these patients may need alteration in their flow versus blood pressure to optimize their perfusion. Next slide, please. So we'll talk, now we spoke about how there are patients who definitely don't fit into the box of a map of 65 to 70, and they have fallen outside the box, either higher or lower. So now we'll just talk a little bit more about all the other monitoring and diagnostic modalities that we can use to guide the blood pressure management in the ICU. Next slide, please. So as we all know, arterial blood pressure is the gold standard. And in these kind of complicated patients, placement of an invasive arterial line is definitely needed because your blood pressure, your standard blood pressure cuff does not give you a second-to-second blood pressure. And also because of variations in patient size, it may not be accurate for all of the patients. So an invasive blood pressure monitoring is a definite must in these kind of patients. Next slide. The other modalities that we can use using your invasive arterial line is also a pleth variability index, which utilizes your changes in your pulse oximetry to predict fluid responsiveness in these patients. And it may not be fluid responsiveness per se, but kind of monitoring how the heart is responding to the volume. Because if you have right-sided heart failure, your cardiac output may not necessarily increase with your volume. So it doesn't talk about the intravascular volume per se, but it kind of gives us an idea about how the heart responds to volume. Then we can also use the pulse pressure variation, which has always been a popular marker of fluid responsiveness. And this also doesn't require any additional equipment beyond an A-line. And then we can also use the stroke volume variation, which has a sensitivity and specificity of 0.81 and 0.80 respectively. And in these patients, almost all of these modalities kind of gives us an idea whether this patient will respond to volume or not. Because our first gut reflex anytime we see a patient with hypotension, especially post-cardiopulmonary bypass, we've always been taught because of the surge response that they go through and everything, the first 24 hours, all they need is volume, volume, volume. But it may not be true for all of the patients, depending on what their cardiac pathology is. And so these modalities kind of help you guide your management as to whether this patient is an appropriate candidate for trying volume response or not. Next slide, please. And the role of echocardiography is very, very important. It's very crucial, like I said. It also determines your etiology of cardiogenic shock and determining the volume status in addition to the other modalities that we use. Valvular pathologies like MR and AI are very important to diagnose and to manage and take into account when you're setting blood pressure goals for your patient. Similarly to RV dysfunction, many of us have seen that post-cardiopulmonary bypass, the RV being the most anterior, always entrains some air while coming off of bypass. And targeting a higher systolic blood pressure in these kind of scenarios is important to kind of wash out those air bubbles, as we call it, and to prevent further RV failure. Next slide, please. Using intraoperative data to guide the post-op management of the blood pressure, post-op management of blood pressure in the ICU is also extremely important, mostly because I think in the ICU, we don't have somebody standing by the patient 24/7 with a TE probe in hand, looking at their cardiac function, looking at all the other modalities and the numbers. And intraoperatively, there is the anesthesiologist at the head of the bed who is doing live TEE throughout for these patients and kind of putting all the numbers and the information, everything together to get these patients successfully off of cardiopulmonary bypass and thriving and ready to leave the OR. So I think using intraoperative data is extremely important, and especially when the anesthesiologist hands off that this patient likes a higher systolic blood pressure, it could be because they have a SAM physiology, or the patient has a thick ventricle, which not be HOCM itself, but they may have a thick ventricle. And these kind of patients do better when they have a higher targeted blood pressure in the ICU. And they have a potential to have catastrophic complications if targeted a lower blood pressure or if their heart rate were to increase with the use of inotropes. So it's very important to gather your intraoperative data and to guide these patients in the ICU appropriately post-op. In aortic arch cases and deep sulcurous cases, we also use the cerebral oximetry in these patients, which kind of gets us a baseline as to where their cerebral sats were, which is also a wonderful indicator, according to me. I've noticed patients need a certain blood pressure for their cerebral sats to be at baseline. But if the blood pressure dips below that, then the cerebral sats drop further. That means the cerebral autoregulation curve has shifted to the right. And so gathering all of this data to guide your management in ICU is extremely important in these critically ill patients to prevent stroke and other complications. Next slide, please. Intraoperative hypotension is also associated with postoperative AKI, MI, stroke, delirium, and mortality, which, again, like I said, if the patient, there are periods which are inevitable while placement of cannulas or for any other reason that the patient can have hypotension intraoperatively. Knowing about the data and monitoring for AKI and myocardial injury and stroke are all very important post-operatively, because having that knowledge kind of tells you what to look out for in the ICU. Especially troponins will obviously not help in patients with cardiopulmonary bypass or cardiac surgery. But if it was any other kind of surgery and the patient had like intraoperative hypotension, then your troponins will rise. You can have increase in your serum BMP markers, and waking up the patient is also very important to make sure that they didn't get a stroke intraoperatively, or using other modes of head imaging if it's 24 hours post-op from that. Next slide, please. For cardiac surgery itself, the studies have shown that higher MARC targets during CPV have been associated with lower post-bypass lactate levels, less incidence of stroke, and lower risk of AKI. I'll talk a little bit about renal resistance index when we move to TEE. Next slide, please. And we have a newer AI guided predictive index that we use in our ICU and in the operating room, which is called the hypotension predictive index. Next slide, please. The HPI is an AI-based algorithmic index which predicts arterial hypotension with high sensitivity and specificity, and it allows for proactive intervention before the hypotensive events actually occur. And the HPI is great because it integrates your information from your arterial line, and it has an algorithmic graphical representation. And it doesn't really just tell you to treat with the pressor, but it gives you an information as to whether you should be giving this patient volume, whether the patient will be volume responsive, whether they need a pressor or an inotrope. So more, this obviously needs to be optimized more. This is a very new modality, and it's part of our research that we use. But I think in the future, AI-guided predictive tools like this will help us in the management of these complicated patients, both intra-op and post-op. Next slide, please. We spoke a little bit about the clinical application about this already. So it decreases the frequency and severity of hypotensive episodes when the protocol is strictly adhered to, which again prevents your mortality and morbidity in the ICU post-op. Next slide, please. So I'm just going to wind up over here in the interest of time. Next slide, please. So my research project and everything is more optimizing tissue perfusion, which is basically moving away from a single predefined target for all patients and moving towards a more individualized approach based on patient characteristics and using innovative technologies to do that. Next slide, please. And the final thought is to, again, I'm going to reiterate this again and again, the ultimate aim is to optimize the tissue perfusion and oxygen delivery rather than targeting a single blood pressure goal for everybody. So I'll stop right here so we can have a few minutes for questions. Thanks, everybody.
Thank you, Dr. Karuna, for your valuable presentation. Hope the attendees have gained knowledge from your presentation. If attendees have any queries, they can unmute yourself and come up with their queries.
That were on ECMO that were also using continuous renal replacement therapy. I have no disclosures. Goals, I'd like to be able to, show you a little bit on how we developed this system to be able to save blood products and blood exposure on our pediatric and neonate ECMO patients. It was a relatively simple step to be able to adapt the use of a CPD bag for whole blood sequestration and using some simple math steps to be able to do this function. And we also use it on other ECMO techniques in our pediatric and neonate ECMOs. A little bit about the background. Using CRRT in pediatric and neonate patients have become more published, especially in the area of pediatric heart transplant, where sometimes it's not just a heart. You might need a kidney transplant as well on these pediatric and neonate patients, or they just need a period of time after cardiopulmonary bypass where they're on extracorporeal membrane oxygenation support in the ICU, and their kidneys have a step back and need temporary support of the kidneys until recovery is available. The CRT circuit contains a large percentage then of the patient's total blood. While it's not as much as the ECMO circuit, is certainly on par with some patients' estimated blood volume. And with these patients, obviously leaving them on circuit makes the most sense, but sometimes transports are needed. So this causes an issue with what you do with the CRT blood. And excessive and unneeded transfusions are not obviously helpful in our pediatric and neonate patients, whether or not they are on the transplant list. Certainly, if they are, increased donor exposure increases antibody risk and risk of not being able to find a acceptable organ. So a little bit about the background. Sequestering autologous whole blood has been published extensively for up to 8 hours in cardiac surgery, where just before you would go on bypass after anesthesia induction, you have, if you're an adult, 400 to 900 mLs of your own blood citrated in a bag or 2 bags before going on cardiopulmonary bypass, and then given back to you afterwards to save this blood from being exposed to the bypass circuit. And this technique was thought we could adapt that process to be able to store blood in other applications. So the CPD bags that we use have enough citrate in them to store 450 mLs of whole blood. And the pediatric CRRT circuit that we were worried about having to throw blood away on had a residual volume of 165 mLs. The citrate bag, as it comes, has 63 mLs of citrate, so the amount of the bag must be reduced precisely. Now, why would we want to use citrate as the anticoagulant? Well, the nice thing is that it's reversible with just calcium administration. It will not cause a long-term increase in patient coagulation values, like, say, another commonly used anticoagulant like heparin. And it can safely anticoagulate the blood for long periods of time, as shown by previous studies using it in autologous blood sequestration in cardiac surgery. And most people have experience with it in some ways in the hospital area over, say, heparin administration. So, quick review of how this is done. So, in the citrate bags come sterile. We open those bags and we remove all of the citrate from the bag using syringes. There's a long end of tubing that then is clipped off as well, which does have some citrate that we don't remove. And that would be when the adaption's needed, because normally these are hooked into a patient's IV to allow for removal of blood, which we're not doing today. So in those instances, we just clip the line, and then we need to correctly measure the blood. This is probably the most important thing. Measure the amount of blood going into the bag, because it's a specific ratio then between the citrate and the amount of blood. So you just can't guesstimate. You need to be able to, either with a syringe, exactly measure multiple times how much blood is going into the bag, or you could measure it with a scale. So assuming that sometimes we have an additional citrate infusion into the CRRT circuit with calcium on the backside to be able to reverse that citrate to help anticoagulate the CRRT circuit. So if that's not happening, this is the simple ratio that you would use. You've got the 63 mLs in the standard 450 amount is what you should get in the bag. And we're going to say that it's going to be 165. So how much of the citrate that we removed do you need to add back in to anticoagulate properly? 165 mLs of blood, which is then 23 mLs of citrate to be returned with 165 going in of blood. Now, let's say you were using a citrate. What you're going to do is you're going to measure the patient's calcium level, and then you're going to measure with the citrated blood in the CRRT circuit, you're going to measure that calcium level there, because that is really where you're going to be drawing from in this application, as you're saving the CRRT circuit. So you're going to have less calcium that's needed, because that's where you're drawing the blood from before it gets calcium introduced. So in this case, if it was 2 milligrams per deciliter, then you would take that ratio there, that the standard is 5 milligrams per deciliter for calcium, and you would have less citrate then. So you'd only need 9.2 returned to the bag if you were using citrate in your CRRT circuit. And this diagram here is another a picture of showing the circuit. So you could actually see the ECMO circuit blood as well, which usually has even more, potentially 200 to 300 mLs for a pediatric patient, and maybe even upwards of 600 mLs on a larger pediatric patient. And so in this setup, we can pull then the circuit blood that was left over. Let's say you were able to wean off ECMO successfully. Well, this child is not going to be able to take that amount of blood in a 5-minute period. So you need to give that volume back over time. And by using the citrate bag, you've got that time. You can give it back over 4, 5, 6 hours safely, and let the kidneys excrete the extra water from it. And now you've saved not only the red cells, which you could save with a cell saver, but you're also going to save now their plasma, their platelets, and all of those components. So in this state, you're going to have the bag there, and you're going to see that there's the stopcock there, which you can add a syringe to be able to syringe back and forth, or like I'd said, a scale could weigh it as well, but you need to make sure that what you have going in is the right amount for your projected amount that you're going to infuse in. In this case, it's going to be different than the 165 ml calculation, because now you're going to take the whole circuit, which usually we calculate about 10 to 15% less than what the circuit volume is, to assume that you might not get it all. But you certainly want to not put any more in, but you don't want to have really substantially less than what you were thinking, because otherwise you'll have an excess amount of citrate that can affect the patient. So other thoughts: during the administration of this blood, once it's been citrated, you're going to potentially need some calcium chloride, either when the CRRT is reinstituted, if you use this to reprime, say, a new CRRT circuit, the volume, or if you give it to the patient, you would still need potentially some boluses of calcium chloride. And this will treat then the hypocalcemia that's caused by the citrate that you use to be able to bind the calcium in the blood to prevent the clotting from happening. And we make sure that we label the bag product with established guidelines. For us, it's a patient ID. It's going to be the time that we processed it, the amount of blood that's in it, the amount of citrate that's in it, and expiration times of when it expires. So results and conclusions. At our center, storage of this blood has prevented us from needing excessive amounts then of additional red cells and then loss of plasma and platelets during a circuit exchange, or when we needed to go on a trip to a area outside of the ICU. Usually it was CTs, where then we would not be able to save the circuit blood in the CRRT circuit and would have to reprime with new red cells and new donor exposure. So we've had no adverse events from using this at our facility. As mentioned before, it saves your platelets and plasma, which you certainly want to save, especially if you're dealing with patients that are in the 5, 6, 7 kilo range, and you're substantially throwing away potentially 20% of their circulating blood volume and accounting for the volume that was in that CRRT circuit. So by doing this, as mentioned before, we'll be able to reduce the amount of blood product usage for these patients during these critical transports or time away from the ICU for chest washouts or any other situations that they might find themselves in. And then more recently, we've been using even more to be able to save the circuit after successful weaning of the patient, and we can use the citrate bags with the correct amount of citrate for the amount that we expect to get from the ECMO circuit to be able to reinfuse that circuit blood and not either throw it away or send it to a cell-saving type device where you're only going to get the red cells back in a saline solution, and you're going to lose your platelets and plasma. And you can also use this in non-ECMO areas with small neonate or smaller pediatric patients where they will not tolerate the reinfusion of the CRRT circuit back into them, displacing that blood in the circuit with saline to push the blood back into the patient. And so you can citrate those types of circuits as well for pediatric patients. And this might be because they're able to successfully come off CRRT, or they might want to do like a 4, 5, 6 hour trial without having CRRT on. And if they would fail that trial, then they would use the citrated blood to reprime a new circuit for CRRT, or if they do pass, they could then reinfuse that blood into the patient. If you have more questions about this, we published this article that goes into detail about what we did to modify the bags, as I've talked about previously today, and then its use in calculations. And these are some of the references to the literature that I mentioned in the presentation. And an acknowledgement to our multidisciplinary team at Mayo. This truly was a multidisciplinary event to be able to bring together the physicians at the critical care level, perfusionists, and the team of nephrologists and their team to be able to bring a protocol together for this to be able to make it functionally and work at any time of day when we might need it, whether it was in the afternoon or in the middle of the night for a CT transport for an emergent head sometimes. We all worked together to develop this to be able to come out with the goal of trying to reduce the amount of blood that we were giving to the patient and the losses of blood they were seeing by not saving the blood from the CRT circuits. And if you have any other questions, there's my email, and I'd be happy to answer any questions.
Thank you, Dr. James Neal, for your valuable presentation. Hope the participants have enjoyed and gained knowledge from your presentation. So could you please drop your email ID in the chat box so that attendees will contact you through email directly?
Okay.
Dear attendees, the email address is displayed for you, and if you have any query with this e-poster presentation, you can contact Dr. Sangfeng through email directly. Thank you, Dr. Sangfeng, for sharing your e-poster in our webinar. Moving on to the next e-poster presentation, we'll have Ilona Golikova from Ukraine. The e-poster is displayed for you, and to a respective doctor through the email ID directly, and the e-poster will be displayed for 2 to 3 minutes for your reference. Thank you. Thank you, Dr. Ayago, for sharing your e-poster presentation. The attendees, you are requested to contact Dr. Ayago if you have any queries. The last e-poster presentation will be from Dr. Gulele Shamal from Pakistan. Thank you, Dr. Gulele, for sharing your e-poster presentation. Now we have come to the end of the day one of the webinar. My heartfelt thanks to all the speakers and attendees who made this event a success with their eminence and presence. We hope to meet you all tomorrow